Good morning, everybody. Oh, hey, Craig.
How's it going?
Good. I was just wondering if everyone else was still asleep.
Well, we got about a third of the class here.
Hmm.
Still got 5 minutes, so 6 minutes.
Yeah. By the way, do you ever hear your voice recorded and it's like, that's what my voice sounds like?
Yep. Yeah, I remember we had an old like cassette recorder when I was a kid, and I remember doing that and going, wait a minute, that can't be me. So yeah.
My voice just sounds really different for me. It's like, I don't, I thought I would have a more, I thought my voice would be clear, but it has a little, I don't know, it's just like, oi.
Yeah, just the way that our ears perceive things when it's from the inside versus when it's coming from the outside, just some different reverberations and resonance and things like that. So it definitely changes what we hear.
Mm-hmm. Yeah.
Hey Craig, I actually have a question.
Yep.
So I printed out the study guide for the exam next week,
Uh-huh.
and for chapter 9,
Yep.
those I think it's like the second, third, and fourth ones. I'm trying to understand what exactly you're wanting us to study,
Um,
or like where that is in the book. It's like
mm,
know what parts of each bone meet up with each other in any given joint. So
so like what would be the joint surfaces? So like if we think about something like the humeral ulnar, the elbow,
mhm.
um, the trochlea is going to be the specific part on the humerus where the ulna makes contact, and the part of the ulna that's making contact there is the trochlear notch. If we look at the radius on the other side, the head of the radius is going to make contact with the capitulum.
Where can I find that in the book?
I don't know that it's laid out specifically that way.
Mm-hmm.
It's just kind of knowing your bony landmarks for most of those ends of the bones. And if they don't have a specific name, like at the phalanx or something like that, we haven't really talked about a specific name. It's just the articular cartilage on the proximal end of the bone or the distal end of the bone. Some of our bigger bones are going to have, specific things that we've identified. So at the knee, you're looking at the lateral femoral condyle would meet up with the lateral part of the tibial plateau, um, things like that. Um,
So, like you said, example elbow, it'd be the trochlear notch.
yeah, so the trochlear notch on the ulna is going to be what makes contact with the trochlea. So those are the two surfaces of those two bones that have that articular cartilage. So they protects them
Got you.
and helps them move.
Okay.
So it's really just kind of where the articular cartilage is, and is there a specific name on that bone for that region of articular cartilage where we're making contact
Mm-hmm.
with the other bone.
Okay. Okay. Um. And then understand how the axis of the joints are related to their planes of motion. I didn't know how specific we were supposed to get with that.
I mean, you should be able to, we'll kind of finish going through the joints today. And so we will talk about some of those things today, but really just for a uniaxial joint, it's pretty easy. If we look at something like the elbow or the knee that really just move in flexion and extension, they're moving through the sagittal plane, but the axis is going to be going through the frontal plane or coronal.
Okay. All right.
If it's something like the shoulder, then we have to kind of identify which action it is, because the plane's going to change, because the shoulder can move in all three planes. It's kind of like if I'm moving my shoulder in abduction, then my axis is going to come in the sagittal plane from front to back. If I'm moving my shoulder in rotation, then the axis is going to be vertical. It's coming straight down through the top of the joint.
Okay. And then our last one, understand which movements occur in which planes and which joints allow for movement in which planes.
Yep. So really pretty similar to that same.
But is it like a combination of those two?
Yeah. I mean, essentially knowing that you have to know, like, the shoulder is multi-axial. It can move in all three planes. The wrist, let's say, is a condylar joint, so it moves in two planes, and the two specific planes it moves in would be the frontal and the sagittal. We don't have it moving in the transverse.
Gotcha. Okay.
Look at a pivot joint, or pivot joints just do rotation, so they only work in the transverse plane.
Got you. Okay, thank you.
Yeah.
Also, I have a comment. Why did you add joints to the testing? I wish we had more time to study it. It's like, so confusing.
It's not till Tuesday. You still got like 4 days.
Yes, I wish I had a couple more weeks.
Yeah, well, a couple more weeks, we're going to be like through all the muscles and everything.
Yeah.
So then we have that on the next test too. So,
well,
I go back and forth with how many tests to have in this class. But, you know, to only have like 2 or 3 major exams in a class like this, you just have so much content on each test that I feel like it's better to kind of take things in small bites rather than try and gorge yourself all at once. I think retention's a lot better if you can just focus on, you know, a handful of chapters at a time rather than having to deal with 8 or 10 on a given test.
Yes. What I was kind of saying is I would have liked to learn about this sooner.
Yeah.
Maybe, like, just to, like, go over it more, or, like, have study groups to talk about it. But I don't know if that would be helpful. Have a good day. I'm just telling you my input version of.
I mean, certainly, I think we are going to, once we get back on campus, we're going to have the tutor available that you guys could certainly come to meet with. If for some reason that schedule doesn't work for you, then I would, you know, you could certainly think about trying to organize within yourselves some small study groups and just meet by Zoom to kind of hash things out if enough people kind of want to participate in that and those kind of things. You know, I can make myself available to a degree to kind of let you guys contact me if you have questions while you're in a study group. If it's time that I don't have, you know, other class commitments going on. So that's certainly an option. All right, looks like it's after 8. So I'm gonna go ahead and get started. Let me get to my gallery view so I can see everybody. I know I'm trying to get roll done while I'm talking to you guys. Missing a few people here and there probably. Let me just catch up on that. And let's see. Olivia's here. All right, I don't see a few folks, but we got most of the crowd here. So we're going to finish going through chapter 9, talk about some individual joints more specifically, kind of focusing on some of the bigger joints. We'll look at how the ligaments are arranged to kind of support those joints and limit certain motions. and talk about which actions and motions that those joints are going to allow. Let me go ahead and share my screen over here. And I want to go over a couple things that I realized after the fact weren't really addressed in this chapter. So we talked about these special movements, movements that really are kind of unique to one or two individual joints in the body that don't occur really commonly. When we think about the common motions, it's mostly going to be flexion, extension, ab and adduction, and then internal and external rotation. So those are kind of our three primary planar movements that are associated with the given, either the sagittal plane, the frontal plane, or the transverse plane. The special movements are usually kind of not in a true plane, or they maybe move through a couple different planes because they're more on the diagonal, or they just have a special name to identify for a given body part. And so we didn't talk about the hand and the wrist. We talked about ab and adduction of the fingers and the toes, and how with ab and adduction of the fingers, we reference whether something's moving away from the middle finger or whether it's moving towards the middle finger as kind of being what defines ab or adduction. But we didn't really address the wrist. And so the wrist, if I'm in anatomical position and standing right here, if I move my hand, my entire hand towards my thigh, I'm essentially adducting it. If I move my entire hand away from my thigh and towards the lateral side of my arm, I'm essentially abducting it. But we don't generally use those terms ab and adduction to describe this motion. We're going to name it based on which of the two forearm bones the hand and wrist are deviating towards. So when I do this and bring my hand towards my thigh, that's going to be termed radial deviation, or excuse me, ulnar deviation. So my ulna is that medial side forearm bone when I'm in anatomical position, and my entire hand is moving toward that ulna side. So that's ulnar deviation. If I go this way and kind of cock my hand up, now my thumb side is moving towards my forearm, and that's the radius. So that's going to be radial deviation. So we've got ulnar deviation and radial deviation, essentially adduction of the hand and abduction of the hand. But we use those deviation terms for that. The other one that we didn't address enough probably was our scapula. I'm going to turn this skeleton around and try and point my camera up a little bit. And I'll probably go ahead and make this bigger. I'll quit sharing so you can kind of see this a little better. All right, so when I look at our scapula, we talked about elevation and depression of the scapula. And so when you shrug your shoulders, that scapula is going to ride up higher. When we lower our shoulders back down, it's going to drop back down. So that's essentially elevation and depression. What happens with when we raise our arms overhead, like I'm holding my arm up to get up to the skeleton, I'm above 90 degrees of abduction at the shoulder. I brought it kind of straight out to my side when I'm holding my arm up this way. When we move our arm up in the air, once we start getting past about 90 degrees of shoulder abduction or shoulder flexion, then we're going to see that scapula need to kind of rotate this way. Let me bring it in a little bit closer so maybe you can see that a little better. If I don't let and you can actually see on this model, because it's got this extra screw, on an actual body, you're going to have muscle and tendons and things like that filling all this space. But as I lift that arm up, wham, the head of the humerus is going to bump up against the acromion of the scapula. And so in order to keep lifting that arm higher up, the scapula needs to rotate. That glenoid cavity, that flat spot where the humeral head needs to meet, has to stay in contact with that round head of the humerus. And if we didn't let the scapula move and kind of follow that arm up, then we wouldn't really be able to raise our arm very high, or we would just be really causing a lot of bony erosion on the underside of that acromion, which does happen. And a lot of people, when they get older, have to have surgery done to kind of clear that space out, because we will get some arthritic kind of bone growth in that area at the end of that acromion. So whether I'm going into flexion, and let me rotate this. If I hit this, again, I'm going to hit the humeral head up against the under the side of that acromion, so it needs to move. in order for me to keep going higher. And so that's where that rotation is going to take place. So upward rotation is that glenoid fossa is going to start pointing up towards the sky as we start raising our arm higher and higher up in the air, whether it's in front of our body or out to the side of our body. And then when I lower my arm back down, then it's going to be depression. It's going to be downward rotation. And same thing if I bring my arm all the way behind my body, way back like this, kind of adducting it behind me, then it's going to do that also. So it's got to kind of come that direction even more. Because again, that flat glenoid cavity needs to stay in contact with the humeral head for that joint to stay in place. So that's kind of a unique movement for the scapula. We don't really see any other thing do that upward and downward rotation. We'll also see different kinds of tilt. And I don't want to get too deep into the tilt because it can be a little bit confusing. We'll talk about that more next semester when you take kinesiology. But we can have tilt where we have what's called an anterior tilt. Let me turn it sideways maybe. Where the scapula needs to go like this kind of. And we can have posterior tilt where it's going to kind of go back this way. And so if I'm going to try and raise my arm as high as I can up in the air, as I start coming up higher, that scapula is going to need to kind of, the bottom part of the scapula needs to kind of push down in towards the ribs. And the top part of the scapula is going to kind of move off the top of our back a little bit to let us get that arm all the way back. If I'm going the other direction and coming all the way down where I'm going to hyperextend that arm, now in order for that to occur, that scapula's got to kind of go into what's called an anterior tilt. And let me move my hand. So it's going to kind of mirror that arc. It's not going to move as much as I'm moving it, but it's this motion where it's kind of riding up on your back and kind of coming back down on your back. And if you feel the spine of your scapula kind of right here, and bring your arm back behind you as much as you can, you'll feel that spine start moving kind of up over the top of your shoulder. And if we bring our arm way back like this, you should feel that spine kind of sliding away from your fingers and dropping down your back a little bit. So that's anterior tilt that we would see with this. We'd see posterior tilt when we do that. And again, that scapula's just got to kind of keep moving along with, got somebody waiting to come in, along with the rest of the humerus in order for that motion to take place. You can also have medial and lateral tilt. And so medial and lateral tilt would be like this or like this. And those are going to take place more with things like internal rotation. If I bend my elbow and I twist my arm this way, so I'm bringing it across my stomach, that's internal rotation. And the farther I come in internal rotation, the more it's going to pull that humerus and want to kind of pull it out of its socket a little bit. And so the scapula has to move with it. And so it's going to kind of do what's called a little bit of a lateral tilt. And then if I go into a lot of external rotation and then pull it back, then it's going to do more of a medial tilt. So that's a tilting with like a vertical axis kind of. So it's twisting this way. Anterior and posterior tilt, it's going to be more of like in the sagittal plane where it's going to go forward or backwards. And again, those are things that only the scapula does because the scapula is free to move because it's not really adhered to any other bones. It's just held in place by all the muscle and connective tissue and things like that. So that's kind of a unique one for the scapula. One other movement that the arm can do that we didn't really talk about, and I guess the hip can do it also, is what's called horizontal abduction. So we talked about flexion. Let me lower this down a little bit. So we got flexion here, we've got abduction here, we've got internal and external rotation kind of here. We can also do what's called horizontal abduction. So a horizontal abduction is bringing my whole arm across the front of my chest. So if you think about like trying to do this stretch for the posterior delt, we're doing a lot of horizontal abduction. We're moving horizontally, which is different than if we're moving in the transverse plane. But essentially, we're bringing that arm across the body here for adduction and bringing it out to the side like this for abduction. The axis is going to be vertical. So it's going to have the same axis as our internal and external rotation coming straight down. That's what we're rotating around essentially, but it's moving in this plane as opposed to regular abduction and adduction where we're here. And then with that motion, the axis is just going front to back through the joint. That's what we're kind of pivoting around in that case. So the shoulder is unique. The scapula is really unique in how it moves compared to the whole rest of the body because we just don't have any other segments that kind of move that way.
Hey, Craig.
Yep.
For scaption, is it called scaption because of how the scapula is moving, or is it just that's what it's called?
So scaption is, whoops, I think I just clicked my computer to restart, so hopefully it's not about to crash on me. If it does, come back in, I'll reboot. Scaption is going to be kind of halfway in between. So it's not really pure flexion, it's not pure abduction, it's kind of in this 45 degree. So it's kind of it's really the plane that our arms move in a lot, kind of at this diagonal orientation, kind of coming up like this to reach for something and back down. We don't usually just go straight up. Often we don't go straight out in front. So scaption's, it's a very functional plane of motion, but it's essentially a combination and kind of halfway in between flexion and abduction.
So there's no different way that the scapula moves for why it has the name?
Not really. I mean,
Okay.
the higher, just like flexion and abduction, the higher up we go, the more that scapula is going to have to upwardly rotate. If our scaption plane is oriented a little bit more towards flexion and extension, where it's a little more in front, then we're probably going to have a little bit more protraction of the scapula. We're going to have probably a little bit more tilt going on too. And then if we come back into more of if our scaption plane is a little bit more towards just pure abduction and adduction, then we're not going to need to see that protraction to accommodate that, since we're not reaching forward with the arms. Does that make sense? All right, let me pull up my chat because I don't see my chat. All right. Yeah, I'm not sure what time the class started because I didn't stop my recording when we were chatting earlier. So it'd probably be about 8 or 9.
I was just doing it for like people after watching the recording.
Okay.
Just make it easier.
Yep. So other questions on that scapular motion? I know we kind of added in a few things there. Did that all seem to make sense to everybody? Hopefully. Okay. Let's go ahead and move forward just a little bit. Let me get back to sharing my screen here. And scroll ahead a bit. All right, so we were kind of looking at this slide here. We kind of started at the top. We talked about the articulation between the base of the skull and the first cervical vertebrae. We talked about the articulation between the first and second cervical vertebrae. Once we get down below C2, where C2 makes contact with C3, and then every other vertebral level below that, we're going to have those vertebrae basically as two joints. The front joint, the anterior joint, is going to be a cartilaginous symphysis joint because we've got the disc between those two vertebral bodies. So like on this model right here, this is a lumbar spine. So we've got the two discs, or the two vertebral bodies with the disc in between. This is the symphysis joint, cartilaginous. I should show you this side so you don't see the disc bulge. And then in the back, on that posterior side, we're going to have two facet joints. And those facet joints are plane joints. And so the whole unit together between two adjacent vertebrae is going to have three joints essentially being part of it. The cartilaginous joint or symphysis joint between the bodies, and then each individual facet joint on the right side and the left side that are plane joints, that are gliding joints. They're going to be synovial. So they're diarthrodial joints, whereas these are not. These are going to be amphiarthrodial. The anterior one is that cartilaginous joint is going to be amphiarthrodial, but the back ones are going to be diarthrodial, where we have a lot of motion. So they have that joint capsule. They're going to have synovial fluid in them. But where the symphysis is, there's no joint capsule, there's no synovial fluid per se. That is just the joint that you see kind of on the surface. Okay. So all the way down the chain until we get to really where L5 intersects with the top of the sacrum, that's going to have that same arrangement. You're going to have a disc in there. You're going to have facet joints. And then once we get down into the sacrum and the coccyx, then everything's fused together, and we really don't see movement with those joints. That's appreciable. So that's kind of our spine. I think we talked about pretty much all of those joints there. So let's move into some of the other unique joints. Most of these will be extremity joints, although we will talk about the TMJ for starters. So our TMJ is kind of a weird joint in that it has a lot of things. We'll classify it as two different joint types. It's got that hinge ability to cause depression and elevation of the jaw, but then it also has that protraction and retraction movement. So it's primarily usually considered a hinge joint, but that protraction and retraction part, it is gliding forward. So that's really more of kind of like a plane joint type of function, that gliding motion. So it does kind of have a dual role. It's kind of unique in that it has a little disc inside there. We have a few other discs besides just the vertebral disc. But anytime you hear about a disc, it's going to be fibrocartilage. In the spine, that disc is what really makes it a cartilaginous joint because it's really adhered down to those bones. A lot of our other discs in the body are more meant as just kind of spacers. They do shift around a little bit, and they just kind of help improve the function of the joint. And that's kind of how the TMJ is set up. If we look at this image on the right on this slide, we're kind of looking inside the joint. We've removed the capsule and kind of some of the ligaments over the top. And so you can see this kind of crescent moon shaped piece of fibrocartilage right in the middle. And so as we open and close our jaw, that disc can kind of adapt and squish a little bit. It just helps make a better contact point. It gives that jaw a little bit of ability to kind of separate the joint if we're really having to open our mouth really wide to put something big in or whatever. But it will shift around, and sometimes it'll get stuck. It'll get, if somebody opens their jaw too much, it might make that disc get pinched too much on the back and kind of shoot forward, and then it can kind of get wedged a little bit. So sometimes people need some work on their jaw to kind of get that disc back where it's supposed to be, because it can make you kind of lock your jaw up a little bit if it gets displaced. So it does shift around a little bit. And we do have some other discs that we'll talk about in the upper extremity. We've got another disc kind of similar to that at the sternoclavicular joint. And then we've got another one at the acromioclavicular joint out here. And then we've got one in the wrist, actually, also that we'll kind of look at. So the other things to know on this one, I don't think there's any test questions that are going to ask you about the ligaments on TMJ. The ligaments that I feel like you need to know, I'll point out as we go through this. But it is good to kind of understand where these things run and kind of what their purpose is a little bit. So we've got a number of ligaments that are named, and almost always your ligaments are going to be named by the bones that they connect. So we've got this first one up at the top, this temporomandibular ligament, going from that temporal bone down to the mandible. Tells you right in the name what it does. And so it's kind of more of a vertically oriented ligament. It's going to essentially prevent that jaw from dislocating inferiorly because it's held up right here. If I start moving that jaw too far down, that's going to get taut and it's going to block that motion as long as it's working and intact. If we look at this very bottom ligament that's coming off the styloid process, if you remember learning about where that is on the bottom of the skull, kind of right here, that's running right down there towards the angle of the jaw, kind of where the ramus of that mandible and the body of that mandible kind of bend. So that's that angle of the mandible, and that's where that thing is. So what motion would that limit? What's going to make that ligament get tight? Its job is to help the joint stay intact. So what do you think that ligament specifically is designed to kind of limit.
Protraction?
Right? Yep. So if we protract that jaw, that's going to pull that thing tight. And that's going to limit how far we can protract that jaw. And so when somebody tears a ligament or sprains a ligament, it means that ligament is going too far. It's either completely torn and it's really not going to block anything, or maybe it's just overstretched. And if it moves 1 millimeter too far or 2 millimeters too far, sometimes that's too much, and that joint can now slip out of place more easily and cause pain. So those are kind of the only, I think, the primary 2 ligaments. There's another one that you see here, this sphenomandibular, and that's kind of running on the inside of the jaw. So it'd be underneath like the soft tissue in our cheek. And it's going to stabilize things kind of more from the inside out. So it's coming off the bottom of the sphenoid bone. And if we think about the sphenoid bone, it's kind of the sphenoid and the ethmoid are those ones that are kind of pretty deep in our skull. And so that's where that ligament's running from. Again, there's nothing that you need to know ligament wise for the TMJ. You should know about the function, that it's primarily considered a hinge joint, but that it also is a plane joint that can glide. And you should know that it has that disc in there. But really, that's kind of the main things about TMJ that I want you to understand. Certainly, we can do a little side-to-side motion with our jaw too, and we do that normally when we're chewing. And again, that's just kind of allowing it to glide a little bit side to side. Remember, those plane joints can kind of let the bones move in a number of different directions within a limited amount of range. All right, so we just talked about the vertebrae kind of to start with. We haven't really talked a lot about the disc specifically or the ligaments that are involved in that. So we'll go through those real quick. We've kind of talked about the motions. So this slide is a nice picture that kind of looks at some of the primary ligaments. And I'll check the test and see if you need to know any of these in the quiz. These are certainly more important for most therapists than the TMJ, because a lot of clinics are going to see people with back problems and neck problems. And so these ligaments can be affected. If we look at the very top, we've got a kind of a cutaway of the disc. We've taken off the vertebrae that would have been sitting on top of it and kind of exposed the inner workings of the disc. So when we look around the perimeter is basically kind of a set of rings of collagen that are going circumferentially. And so that's pretty tough tissue, just connective tissue that's helping make up that fibrocartilage disc. In the center, we have what's called the nucleus pulposa, and that's more of a gelatinous kind of material that can kind of squish and move around a little bit. And so when we bend forward, when we bend to the side, when we rotate our back, all those motions are going to kind of compress on that disc, and having that nucleus in the center gives that disc the ability to kind of get flatter on one side. If we're leaning over, like say if I'm really bending to my right side like this, those 2 vertebrae are essentially going to be mashing down on one side. And because the disc has that gelatinous center, that jelly can kind of push over to one side. The side where the bones are closest, the side that we're bending to, the bones are going to be really close. And so you're going to have more tissue, essentially, more of that gelatinous material is going to push over that way. And this model actually has mimics what a herniated disc or a disc bulge. That red portion that's sticking out shouldn't really be there. And that's what happens when the fibers of the annulus, the circumferential fibers of that disc, start to fail and tear. Is that disc material, that jelly that should be inside, gets squished out. And a lot of people liken the disc to like a jelly donut, where the dough part is essentially like the annulus fibrosus. Obviously not nearly as tough as collagen. Dough is pretty weak, especially on a donut, but the inside has that jelly center. And if we squish it down on one side, it's going to make that donut tear and that jelly is going to squirt out. And so that's kind of what we try to help people avoid. And if they do have that, then we try to help them do some techniques to try and see if we can get that jelly back inside the donut, which is harder. Like you would imagine, if you imagine a real donut, it can be kind of hard to get that jelly to go back where it was once it escapes. So that's kind of the basics of how that disc is set up. Again, a perimeter, both top, bottom, and all around the sides of tough collagen. Again, the top and the bottom are going to be adhered and stuck to the vertebrae that it touches. But in that center, it's much more of a gelatinous material that can shift around and cause some different stresses.
So can you literally slip a disc? Can it actually completely fall out of line?
The whole disc won't go out. All those terms kind of refer to the same thing. Sometimes it's different amounts of severity. So if you hear about a slip disc, a bulging disc, a herniated disc, a ruptured disc, they're all just gradations of the same injury. But the actual top and bottom of the disc are still going to stay stuck to the bone. They're pretty tightly bound to that bone. What slips is the jelly, essentially. When we get a tear in the sidewall, essentially, it's going to slip out. All right, so we've got a bunch of ligaments, and because these are all going to this from the same type of bone, you can't just name it like we saw with like the temporal mandibular, going from one distinct bone that has its own name to another one. Pretty much all of these ligaments are going from one vertebrae to the next. So you can't just call it the vertebral ligament because we got a whole bunch of them. So it's named more on the bony prominences, or they just have kind of unique names that are made up, or it's named on their location and direction. So if we look at the back on the posterior side, we've got the spinous processes jutting out, and this one little kind of thin ribbon of ligament that essentially runs from tip to tip all along the length of our back directly posterior. This would be the most superficial ligament that you could see or touch, is this supraspinous. So it's sitting on top, supra, of the spinous processes. So the name tells you pretty much where it runs, supraspinous. If we go to these next ones where you can kind of see these fibers running diagonally, then we've got our interspinous. It's running between the spinous processes. So if I look at my model right here, the supraspinous are going to go directly from here down to here, down to here, down to here, all along the top. The interspinous is going to fill this open space on this model kind of right here. So you're going to have kind of essentially one joining each vertebrae running separately. So you have a supraspinous ligament between L1 and 2, between L2 and 3, between L3 and 4, and so on down the chain.
So those aren't connected to each other. They're just connected from one vertebra to the next.
Correct. Yeah, so they're not going to be as one continuous piece like we see with the supraspinous. They're going to basically just stop on the underside of the superior vertebrae and touch down on the top side of the inferior vertebrae. The next one that you see kind of right in this space, and it's essentially running from lamina to lamina, all along the inside of where your spinal cord would be. So this yellow thing here is the spinal cord. So it's kind of running on the inside of that column, but essentially just touching down where the lamina are on the bone. If you remember the lamina, we had our transverse process, we have our spinous process, the lamina is kind of that section of bone in between. So it's on the back side. If you're looking at somebody from the posterior view, it's going to be inside of that spinal column, but running kind of posterior laterally all the way along that spinal cord area. When we get inside the spinal cord, basically right behind the body, so if I have one that's running right here, that's running just straight down the center, but on the posterior side, or I guess it would be the anterior side of the spinal cord itself, that one we call the posterior longitudinal ligament. So longitudinal is that vertical orientation. We have an anterior longitudinal ligament that's going to go all the way along the front of the vertebral bodies. The posterior longitudinal ligament goes all the way along the posterior side of the vertebral bodies. But it's in the PLL is inside of that spinal canal. The ALL is not. It's on the front. And essentially in front of the ALL would be like all your internal organs. Your stomach, your intestine, your bladder, all that kind of stuff would be here. So ALL on the front of the vertebral bodies, PLL directly parallel to ALL, but running all the way through the spinal column itself, where the spinal cord would be. And then on the side in through here, we've got what's called ligamentum flavum. And I don't even think I gave you the name of that one. That's the one that's behind the lamina, essentially. And so that flavum, the way that I keep that one straight, that we've got FLA, so LA, and the lamina has LA to start with. That's how I kind of remember what part of the bone it's related to. I don't think the terms are necessarily related. It just helps me remember that the flavum, because it's got LA right there at the start, is right behind the lamina of the vertebral body, or the arch of the vertebrae. Does that kind of make sense? So again, I'll look over the test and shoot you guys out a message, since I know the test is coming up, to clarify if you need to worry about memorizing all those right now. For sure, you'll need them in later classes when we get into ortho. Absolutely, you need to understand those ligaments, but I can't remember off the top of my head if there's questions about it on either the test or the quiz. Definitely you want to know how the disc is put together, for sure, and how those two sets of joints that make up the vertebrae work, as far as the cartilaginous symphysis joint and then the two plane joints that make up the set joints on the backside. All right, let's talk about the arms and legs and kind of look at each of the primary major joints that make those up, and we'll just kind of work our way from top to bottom and look at all of these right here. So these first two joints, the sternoclavicular and the acromioclavicular, they both have that term clavicle in the name, so they're related to the two ends of the collarbone, essentially. The sternoclavicular joint is that more proximal one right here. The acromioclavicular joint is right there, and it's where the scapula is going to join the clavicle. So the SC joint, sternoclavicular joint, that is literally the only bony attachment for our whole arm to the rest of our body. Because the AC joint out here attaches the scapula, but the scapula is really free to move. So the only thing really holding our arm, the only true bony joint holding our arm on our body is right here, which is pretty crazy to think about. Certainly we've got attachments out here to the scapula, but again, that scapula can move lots of different directions. So it's really kind of a unique joint. So let's look at the SC joint up close a little bit. So this book considers the SC joint to be a saddle joint. Most other references that I've seen consider it to be a plane joint. And so there is some controversy about it. I can kind of see where you could consider it a saddle joint. And I don't think I talked enough about what makes a saddle joint a saddle joint. If you think about a horse saddle, Western style saddle, from front to back, you've got this curvature kind of like this, right? If I'm sitting on my horse facing forward, I've got the horn, and then I've got the back kind of ridge that blocks the back of my pelvis. So I have this concave orientation from front to back with that saddle, but then my legs have to hang off the side. So in the center of that saddle, we have a convex shape so that our legs and our pelvis can be centered over it and our legs can kind of drape down over the sides. So it's a saddle joint. The ends of the bone are kind of shaped that way. In one direction or one plane, we have a concave section. In another part, we have a convex section. And so if you look at your two hands and kind of twist one hand to the other and put your web spaces together where the thumbs are, that's kind of how a saddle joint is going to work. So if I have my right hand right now oriented in the sagittal plane, my left hand is kind of turned the other way, I've got this concave orientation here. And so the one bone can move relative to the other bone this way, front to back, but it can also go side to side this way as it rocks back and forth, like where your legs would be draped over a saddle. And so with a saddle joint, the ends of both bones kind of fit together that way. And so it lets that bone, that joint move in a few different directions. And then we also get a little bit of a twist. And so our thumb is our primary saddle joint that pretty much every text considers to be a saddle joint. And so that's what gives that thumb the ability to flex across our palm, extend away from our palm, but then also abduct and pull that palm away from the palm this way and back in. And then it gives us that diagonal part is what gives us that opposition movement. So when we look at the SC joint, if you put your hand on your collarbone right here and reach way out in front of you, and especially if you're on the lateral part of that clavicle, you're going to feel that clavicle basically move anteriorly. It's moving from that joint and letting you, in order to reach really far forward, that clavicle needs to basically pivot and face more anteriorly. And then if I bring my arm way back behind me, that clavicle's got to go back. Or if I just retract and like I'm doing a rowing motion, that clavicle is going to move posterior like that. So it's moving kind of this way. In that case, it kind of has a vertical axis, kind of coming straight down to the top. So it's kind of similar to what we would see with like horizontal abduction, moving this way. Now, if you have your hand on that collarbone and you just shrug your shoulders, well, you're going to feel that collarbone go way up like that, right? And so that's kind of more like abduction. Your axis is going to be coming straight through the joint this way from anterior to posterior. And that's what gives it the ability to kind of pivot and move upward and move downward. Again, it's attached here, but the whole rest of that, what we call the shoulder girdle, the clavicle and the scapula and the humerus kind of all together, is going to move through space when we do that. And then the third motion, if we do a lot of shoulder flexion and shoulder extension, if you kind of grip your clavicle, kind of pinch it on the front and the back, raise your arm way up. When you get up towards the top, you're going to feel that collarbone kind of twist a little bit. And if you bring your arm way back behind you, you're going to feel it kind of twist a little bit the other direction. So it's kind of rotating in space when we do that. And so that's kind of this twisting motion. And it's rotation, but because of the way the scapula is put on our body, it's not really in the transverse plane like the other rotation type motions. So it's definitely a funky joint. And a lot of books consider all those interactions just like a plane joint, where it's just gliding in all those different directions. But this book does consider it to be a saddle joint. So any test question, I will take either one, because different references say different things. But you would be safe to answer that this is a saddle joint. You'd be safe to answer that it's a plane joint. I'm not going to ding you for either one of those. If you tell me it's a hinge joint or something else, or a condylar joint, then yeah, you're not going to get it right. But I'll take either saddle or plane for that one. All right, let's look at anatomically kind of what it looks like. So again, we've got a little disc in there, just like we had for TMJ, and we're actually going to have another little disc at that AC joint as well. We do have a number of ligaments here, and I think these you probably should know. There's just a couple to think about. We have what's called the anterior and posterior sternoclavicular ligaments. And so those are basically going to run more or less horizontally, joining those two bones this way in the front, and then also behind. So you can't really put a finger on the posterior sternoclavicular ligament very well. The anterior one you definitely could, because it's basically right there. We've got another ligament that runs right across the top that spans from one clavicle all the way across the top of the manubrium and then over to the other clavicle. So that's the interclavicular ligament. So it's basically kind of making like a U with a little dip in the middle where it makes contact with the top of the sternum right there. And then coming from the underside, and this picture doesn't show the interclavicular ligament. The only other one that we see is down below. So coming up from the first rib, very close centrally, you're going to have a kind of a vertically oriented ligament that's essentially helping keep the clavicle from lifting up at that medial border and separating this way. So that anterior sternoclavicular ligament is going to prevent that clavicle, that sternal end of the clavicle, from going too far forward. The posterior one is going to prevent it from going too far backwards. The interclavicular is going to kind of keep it from separating apart this way a little bit. And then the costoclavicular ligament, costo being rib, the name tells you where it goes, costo to the clavicle, is going to keep that center part of the clavicle from popping up in the air this way. So those are kind of how those are set up to provide support to the joint and keep it from moving too far. So just 3-4 ligaments on that one to kind of keep track of. Our AC joint, and that's the most common way that you'll hear it referred to, it's acromioclavicular. So it's going specifically from the acromion of the clavicle, of the scapula, excuse me, to the acromial end of the clavicle. And let me grab my shoulder model here. And I'll kind of switch my screen for just a sec here. All right, so here you're looking at the front of a right shoulder, okay? I'm gonna tip it so you're looking at the top right here. And so this gives you kind of an idea of how these things are oriented. The clavicle is way up here, back of the scapula, the spine is right there to kind of get you oriented. And so it's coming in at, you know, whatever angle this is, maybe 45, 60 degree angle or something like that. But right here is your AC joint. So here's the acromial end of the clavicle, and there's the acromion itself. And so they both are kind of flatter areas that are just kind of butting up against each other. It's considered to be a plane joint, essentially a flat surface meeting up with a flat surface. This ligament that's shown here right on the top, that's going to be our superior acromioclavicular ligament. We're going to have it bracketed on the bottom. So right underneath in here is going to be our inferior acromioclavicular ligament. So it's kind of like a little sandwich with the two ligaments being the pieces of bread. Superior AC ligament, inferior AC ligament. The other ligaments that help support this area are going to be these right here. Who remembers what this bony landmark is? Right here. So I'm kind of tracing my finger along.
A conoid process?
Close.
The coracoid?
It's coracoid. So coracoid process, and that's the one that you can feel kind of right in here. Doesn't feel good when you mash on it. So that's the coracoid process. It has two ligaments that are running up and attaching onto the underside of the clavicle, kind of like we saw with that costoclavicular ligament in here. So it's going to help keep that from pulling up. Those are going to be called the coracoclavicular ligaments. So it's coming off the coracoid going to the clavicle. So coracoclavicular. I don't remember if this test has asked you to differentiate between the two of them, but they are called the conoid and the trapezoid. The conoid is the one that's more centrally located, so the one that's more proximal or medial. The trapezoid ligament is kind of shaped like a trapezoid, and it's going to be closer to the tip. And that's how I keep them straight. The one that starts with a T is closer to the tip laterally. The one that starts with a C, the conoid, is closer to the center medially. So they're both considered to be costoclavicular ligaments, but they are two distinct separate ligaments with just slightly different orientations. So they would support or resist forces in different areas of the clavicle that are trying to separate them. So really common injury out here is called a separated shoulder. And so a lot of you may have heard that term before. A separated shoulder is not really about the glenohumeral joint. It's about this acromioclavicular joint. And if somebody gets a separated shoulder, they've sprained either the acromioclavicular ligaments or the coracoclavicular ligaments. And so these ligaments that are out here on that side are holding that clavicle down and attaching it to the scapula. So when we sprain those, that clavicle is going to pop up and we're going to lose that integrity, and we're going to lose that attachment that helps us pull on the scapula when we move the clavicle. So it does create a lot of problems. It's a super common injury for like quarterbacks when they get sacked and they get slammed down onto the ground and driven onto their shoulder. They'll either break their clavicle or they'll get an AC separation, a separated shoulder. And that clavicle is now free to move. And so we need to put them in a sling and essentially try to elevate that humerus. If my clavicle is sticking up like this because those ligaments laterally are torn, if I can put that arm in a sling, I can kind of bring the scapula closer together, and it's going to have a better chance to try and heal itself and reconnect those things. But it almost never joins quite as tightly as it used to. And so people that have a history of that, they'll have a little bit higher clavicle on the one side, and you can kind of press down on it and it'll kind of move a little bit. Sometimes they call that a piano key deformity. Just like you imagine you're pushing down on the piano key going ding, 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 ding. That's kind of what you can do on that lateral tip when somebody has a history of a separated shoulder and it didn't heal well. They have too much of that motion, and it affects the whole shoulder. Because if that scapula is not being pulled on correctly, it's going to change how the humeral head is fitting in that fossa, and it creates a lot of problems. So those are kind of the ligaments to know on that. Let me share my screen and you can look at the picture a little bit, and that might help kind of reinforce what we're talking about. I thought I had a picture. I think there it is. So yeah, if we look at this top picture of just the drawing, superior acromioclavicular ligament on the top, the inferior would be kind of the underside one. This image just gives you one name for them. And then we've got the two coracoclavicular ligaments more medially. Again, this one that I'm kind of tracing my cursor over right now is going to be the trapezoid because it's closer to the tip. This one over here, that's more cone-shaped, that's the conoid, and that's closer to the center. So that's closer to in the direction of the sternoclavicular joint. So those two ligaments there, you definitely want to know. This image is also looking at the glenohumeral joint. So the glenohumeral joint is the shoulder itself, what we think of as our ball and socket joint. And I forgot to mention, the AC joint is a plane joint. So it allows a little bit of motion between that scapula and that clavicle kind of in all directions. And when we think about all those arm movements that we can do, it essentially gives it a little bit of wiggle room with that plane joint. But the bulk of the motion is going to take place at that glenohumeral joint itself. So it is a ball and socket joint. It's triaxial, multi-axial. It can move in all three of our primary planes that we talk about. And it has a few ligaments to be aware of. I think the most common ones that we'll ask you about are going to be the three different portions of the glenohumeral ligament itself. So it's telling you what it runs. It runs from the glenoid to the humerus. And we have a superior, we have a middle, and we have an inferior. We don't really consider to have a posterior glenohumeral ligament. We do have the joint capsule that surrounds the back part of the joint, but most references don't give the joint capsule and identify specific ligaments on the posterior side. They're all kind of on the front. And so I'm going to hold up my model right here. And let me quit sharing my screen and we can kind of talk through those a little bit. So right on the top, if I turn this bone so you're looking kind of straight down, you've got that, this is the head of the humerus on the very tip-top surface. And so that's going to be our superior glenohumeral ligament. It's really kind of right underneath that acromion. And it's running and attaching to the glenoid, basically tucked underneath where that AC joint is. The middle glenohumeral ligament on this particular model is going to be this one here. And it's kind of top middle, let's say. And then we've got our inferior. And our inferior is the biggest one. And it hangs down. It really kind of covers the anterior lower half and then dips down kind of into the axillary area. And so this is the one that's really loose. It's kind of baggy underneath there. And it needs to be kind of loose and baggy underneath there so that when I try and raise my arm all the way up, I've got the ability to go that high before things tighten up. But all these ligaments are going to kind of block certain motions. So this one on the top, it's running right across the top to that humeral head. If I move my humerus across my body this way and really try and adduct it a lot, that's going to make the head of the humerus go laterally. You can kind of see it as I move this joint a little bit. If I push the distal part medially, the top part wants to move laterally. And that's going to put tension on that superior glenohumeral ligament. So that's the motion that it's meant to kind of stop, essentially. When we look at the middle, kind of right here, what motion do you think that would make that get tight? Okay, so Mo's kind of going this way. So if we're going into a lot of either horizontal abduction, that would put stretch on that middle glenohumeral ligament. Also, if we do a lot of external rotation and I twist that humerus laterally, that's going to tighten that up. Our inferior glenohumeral ligament, it's mostly going to get tight when we go overhead because that's going to take up the slack in that. So those are kind of our three primary ones that you should know for the glenohumeral joint. And then the AC joint, again, anterior and superior, superior and inferior acromioclavicular ligaments, and then our two costoclavicular ligaments. This model's got a few other things on it too, as does your picture, but I think those are the only ones that you really need to be aware of with that. Okay, so the shoulder is tough. There's a lot going on, and it has a lot of unique movements to it. So it is a tricky joint to kind of get a handle on. All right, let me go back to sharing. I haven't gotten very far, so I better speed up a little bit. We're only on the shoulder. All right, elbow. It's a hinge joint when we talk specifically about the humeral ulnar and the humeroradial joints. So it's almost like a dual hinge. We've got the more lateral hinge, which is the humeroradial. We've got the more medial hinge, which is the humeral ulnar. The humeral ulnar is really more of the true elbow itself. So the trochlea of the humerus is going to make contact with the trochlear notch of the ulna. And so Whitney, this is kind of what you were asking me about before class started. The capitulum of the humerus is going to make contact with the head of the radius. So if we look at our skeleton, pull him in really close, so you can kind of see that arm. Again, this whole section right there is your trochlea. This is my ulna medially, and that's really where we have the most hinge motion going on. The head of the radius is right there. The capitulum is right there. And so it is going to glide along there. The top of the radius is very much like a golf tee. It's like a little circle, but it's got a little indentation, kind of like a little dimple, a little divot. So it looks very much like a golf tee. And this capitulum is kind of a rounded little condyle. And so it's a good little fit right there. We do have a few ligaments when we look at that joint. You can see them listed. Well, no, you can't see them. Maybe, yeah, you can see them listed there. So the radial collateral ligament and the ulnar collateral ligament, and then we have the annular ligament. And so anytime you hear about an annular ligament, it's almost always going to be a circumferential kind of ligament. And we have a whole bunch of ligaments named that at various joints in the body. So the annular ligament, if, let me switch my screen share, is essentially wrapping around that radial head. Let's see if I can bring him in a little closer even. So it's just going to encircle it and it holds it in place. So it's essentially a part really of the proximal radio-ulnar joint where the radius hits up against the ulna. That's really what the annular ligament kind of supports. That's that pivot joint. So that's kind of its primary role. The radial and ulnar collateral ligament are more about the elbow itself, holding those things together. And so if I bend the elbow like this, you're looking at the radius side of this arm. So the radial collateral ligament is going to run kind of laterally through kind of all this space. And there's a few different sections to it. And it's going to provide support from the joint if I try and my forearm wants to move too far medially, if I'm in an anatomical position. That's what's going to make that radial collateral ligament get tight. Ulnar collateral ligament is going to be on the other side. It's going to be running over here. So if I turn my arm out the other way, now you're looking at the medial side. It's going to essentially run from the medial epicondyle of your elbow and attach down onto that medial edge of the ulna. So it's essentially right here on your arm. Your medial epicondyle, really easy to find, but that ligament's essentially running right through here. And this is a really common one for pitchers to injure. If you've heard about baseball players having to have Tommy John surgery, that's because they've torn that ulnar collateral ligament. That's the one that is injured in that case. And if you think about the throwing motion with a pitcher, I don't know if you've ever seen slow motion pictures or slow motion video of somebody throwing. When they start throwing towards home plate, their humerus really accelerates forward and their forearm is kind of lagging behind. And then they kind of whip it through to get a lot of velocity. And so that acceleration of the humerus causes that you got a weight in your hand with that baseball or softball, and it essentially just lets those bones kind of gap a little bit and puts a lot of stress on that ligament. And if you're throwing every day, day after day, and trying to put spin on the ball and trying to do all kinds of things, it just starts overstretching and damaging that ligament, and then eventually it tears. So that's the most common ligament injury that you'll see at the elbow. So those are the three ligaments to know with the elbow. And again, they're telling you where they run: radial collateral, ulnar collateral. Again, they're part of the elbow, so they're attaching to the humerus. The only one that doesn't really attach to the humerus is going to be that annular ligament. And probably the best view for all three ligaments is this kind of anterior view on the left. Oh, you guys aren't seeing my screen. Let me do that. I don't think I hit the right thing. Let's try that one more time. There we go. So this anterior view right here, this horizontally oriented one, is essentially going from the ulna, wrapping around the head of the radius, and then it would come around the back side. That's our annular ligament. And then again, this is the radius on the left-hand side of this picture. So the radial collateral ligament, and then this other bone on the inside is the ulna, and our ulnar collateral ligament. So those are the three that you kind of need to know. And if you're looking at one of these side views and you're not sure, just read which image it is. So this one is on the top right, says the right elbow lateral view. So then that should orient you well. The lateral bone when I'm in anatomical position is the radius. So we're looking at the radial side. If you're looking at the medial view, then you're looking at the ulnar side of that elbow. So pay attention to the labels, and most of these images are going to be labeled so you can kind of get oriented to them a little bit when we look at those things. So that's the elbow. Let's look at the wrist. So the radiocarpal joint is the proper name for the wrist. You'll notice that there's no ulna mentioned. We mentioned the radius and we mentioned the carpals. So the ulna doesn't really make contact with it a whole lot. Think of kind of like how the fibula doesn't really make up contact part of the knee. It's kind of below it. That's kind of how the ulna is at the wrist. The radius is skinny proximally and wide distally. The ulna is the opposite. The ulna is bigger proximally and it gets skinny distally. So those two bones kind of have a different opposite shapes. And so that broader distal end of the radius is where most of those proximal carpal bones are going to make contact to form that joint. And we had 4 bones in that proximal row, and you only see 3 of them listed here. And that's because that pisiform is kind of right on top of that triquetrum bone, or triquetrum bone. So those 3 primary ones down here, the scaphoid, the lunate, and the triquetrum, are going to be the primary bones that make contact with the radius to form the wrist joint. And we do have another disc in the wrist. So when we look at this view here, this is a right wrist. So here's the radius is much bigger at that distal end than the ulna. the disc is essentially on the ulnar side. And so you can see that it kind of, we have a little bit of a step off where the ulna doesn't go quite as far down distally into the wrist as the radius does. And that disc kind of fills in that gap so that now we have kind of a more seamless kind of semicircle shape to make up that wrist joint. And so this is considered to be a condylar joint or biaxial when we look at that orientation. So if it's a condylar joint, which motions can it do? How many planes does it move in? It's condylar. When you sing one, now she's changing her mind, letting it drop a little bit. There's actually going to be two. So if it's condylar, it's considered to be biaxial. And so it's going to do, if we say bye-bye, we're doing flexion and extension of the wrist, okay? And then if we do the little beauty queen wave, then we're kind of doing more ulnar deviation and radial deviation, which is essentially like abduction. So it's going to move in the sagittal plane to do flexion extension. It's going to move in the frontal or coronal plane to do that radial and ulnar deviation. So those are the two motions that it can do. And if you can do those two motions, then you can also do circumduction. Okay, so to do circumduction, you need at least those two axes of motion. And it lets us do those, all three of those. So that's kind of the orientation of the wrist. You can look on this image right here and you can see some little pieces of ligament attaching each of these carpal bones. And there are, you don't need to know the names of all of them, but essentially they would be named by whichever two bones they're joining. So like the scapholunioid ligament or something like that, but you don't need to worry about that. I don't think you need to know any of the ligaments in the wrist for this class. Know that it's got a disc, know which bones are involved in that articulation, know which motions happen there, and which planes those things occur in, and you should be good. You have a question, Allison?
Is there a disc between the radius, where the radius meets the elbow joint, or no?
I don't
Because it
believe
doesn't
so.
kind of touch.
Yeah, I think they just kind of touch. You would think it would be because there is kind of a gap there, but I don't think there is. All right, let's look at the leg. Actually, let's talk about the hand a little bit because the set of slides doesn't have the hand. So when we look at the hand, we've got that radiocarpal joint, and then we have just the intercarpal joints. And so those intercarpal joints between all those 8 little bones are all going to be plane joints. They can move in all the different directions, but just not a whole lot. And we do need that extra motion to really improve how far we can move our hand back and forth. But they're not really rotating around a certain point. They're just sliding past each other. When we get to the end of the carpals, then we're going to hit the metacarpals. So the metacarpals are essentially the bones in our palm. And that articulation there, we call it the carpo-metacarpal joint. So where the base of the hand touches down to the distal row of those carpal bones, that's the CMC joints, carpo-metacarpal. And they're all plane joints with the exception of our thumb. So the CMC of the thumb is that saddle joint. So it's right here. It's not this one right there. That's our MCP. It's going to be the CMC. So the CMCs are these ones that are basically right there at the base of the hand, carpo-metacarpal. MCP are going to be our knuckles. And those are condylar joints, so they're biaxial. So that's what gives us the ability to do flexion, extension, and abduction, and circumduction as well. Okay.
Greg,
Yep.
when it comes to the hand, I know some people aren't able to touch fingers, like certain fingers. Is that because they're not flexible in some of those ligaments or tendons, or is it because they lack those? Because I know some people don't have certain
Yeah, I mean,
ligaments.
really the the thumb and the pinky, the pinky is considered to kind of have like a modified saddle joint. So it does have some ability to oppose. You can see how far across my palm I can draw my pinky. But the other 3 digits really shouldn't, you should be able to touch your thumb to all your fingers. That would be considered normal range of motion. But the digits 2, 3, and 4 shouldn't really have much ability to oppose. They're mostly just going to be either flexing or they're going to be adducting and abducting.
Gotcha.
When we get out to our IP joints, those are just hinge joints. Okay, so when we look at our thumb, we just have one IP joint because we don't have a distal and a proximal. We just have the 2 phalanxes. That's a hinge joint. And then when we look at our fingers, our proximal interphalangeal joint and our distal interphalangeal joint, those are all just hinge joints. They just flex and extend, one plane, just like the elbow, just like the knee. Okay, so that's our hand. All right, let's look at the leg. And I do think the leg's a little easier because the hip's a lot easier than the shoulder. The shoulder's a lot trickier to get a handle on. So let me skip through that and we'll get straight to the hip. So the hip is also a ball and socket joint. It's a much deeper, more stable socket than the shoulder. It can still move in all the planes that the shoulder moves in, but it doesn't have as much range of motion really with any of those things. We need it to be more stable because we weight bear on that leg, and we have to carry our body weight and support our body weight, where the shoulder doesn't usually do that, unless you're walking on your hands. So both the shoulder and the hip, which I didn't mention on the shoulder, have what is called a labrum. And so a labrum is essentially just a circular rim of fibrocartilage. And so it's going to be sitting, if we think about the glenoid, let me unshare my screen. So I'm kind of facing the glenoid right to you. So here's the glenoid fossa, glenoid cavity right there. All around the perimeter of that, you're going to have an extra rim of cartilage that essentially just deepens the socket a little bit. So it helps that socket stay in contact with the humeral head a little bit better. If you imagine like a dart, how the suction cup on a dart, not like sticking, not like a dartboard dart, but like a suction cup dart, how it has that kind of rim of kind of flexible rubber. That's kind of how that rim is going to be. It's not going to exist in the center where the bones are making contact, but it's going to deepen that socket. And we see the same thing on the hip. So if I look at my acetabulum, a way more pronounced rim, but you're still going to have a rim of extra cartilage in there. And people will tear their labrum pretty commonly, and usually it doesn't fix itself very well. Like most cartilage, it has a pretty bad blood supply, and a lot of times it'll need surgery. People that have a torn labrum on either joint, a lot of times you'll get a lot of extra joint noise, kind of clicking and popping and stuff like that, as that piece of torn labrum kind of shifts back and forth a little bit and gets pinched in there. So they both have that labrum. Ligament-wise,
Oh, never mind.
whoops, let me go back. You have a question, Eric?
Yeah. Do you want me to bring the nerve up, for example, or are you good?
No, I think I'm good. Thanks, though.
Okay, then just forget me. Keep going.
Yep. So we've got 4 ligaments that I want you to know around the hip. 3 of them are structural. 1 of them is really just designed to protect an artery as much as anything. So the 3 that really support the outside of the joint are going to be these top 3 on this list. The iliofemoral, ischiofemoral, and pubofemoral. Hopefully you can guess where those run. Iliofemoral from the ilium to the femur, ischiofemoral from the ischium to the femur, pubofemoral from the pubis bone to the femur. And when it talks about femur, it's really just referring to kind of the neck, essentially, of that femur. It has to extend past the head to encapsulate all of the head of the femur, but it's going to go a little bit beyond that and anchor into a little bit more close to the, kind of right where the angle is on that femur. It's going to be right about in there. So we'll look at the picture. And then we'll talk about the teres ligament too. So you can kind of see the trochanters, the greater trochanter and the lesser trochanter, and the head you don't see because it's all covered up with all these ligaments, but that's where those ligaments end, is kind of right before you get to the trochanter. So they kind of extend through that whole anatomical neck and touch down. So you can see that there's kind of this, some diagonal fibers running in this image. This one that I'm on the far left is the front side. So we're this sloping bone coming down towards the front is our pubic bone. And so the pubofemoral is this more medial section that's going to run kind of anteriorly. The iliofemoral is coming from a higher point where the ilium is. And this one is called the Y ligament. It's essentially an upside down Y. So if you're a University of Utah fan, sorry, there's no U ligament. I'm not a BYU person, so I don't really have a dog in this fight. But it is the Y ligament. It's really more of a V, in all honesty. So maybe it's the UVU ligament. I don't know. But it's kind of oriented this way. So it's like an upside down V. And so which fibers it is of that V or that Y kind of determine what motions it's going to limit. When we look on the back side, now we've got our ischium, this more inferior part of the pelvis. And these are really kind of horizontally oriented fibers. So that's our ischiofemoral ligament. So those are our three supporting kind of perimeter ligaments. When we look at this bottom image on the left, you can see the teres ligament. And that term teres means round. And we'll hear about it with some other ligaments and some other muscles too. And there's a little artery that runs inside of that teres ligament. So that connective tissue is just protecting the artery. That artery goes to that little indented point on the end of the femur called the fovea. So right there where on my femur model where I've got that little hole, that's where that teres ligament is going to attach. That's where that artery is going to enter into the head of that bone to give it blood supply. So those are the four ligaments to know.
Is that labeled as teres ligament, or is that the one that they've labeled ligament of the head of the femur?
I think that's, yeah, they call it ligament of the head of the femur. But the other name is the teres ligament. Sometimes they'll call it the round ligament because teres means round, but teres is the name that you should probably be familiar with. But the way that they've got it described tells you pretty much where it is. But it's not really, like I say, it's not supporting the joint. It's not really keeping the head of the humerus or the head of the femur from pulling out a socket. It's strictly just to protect that blood vessel. Bo Jackson, who many of you have probably heard of, damaged that artery. His hip, when he got tackled playing football, it basically pulled that hip out of socket and then it popped back into place. And when it pulled out and popped back in, it either tore the artery by pulling too far, or when it popped back in, it kind of pinched it and it cut off blood flow. And so he ended up, the head of his femur developed what's called avascular necrosis. Avascular meaning a lack of blood flow, necrosis basically meaning tissue death. And so the head of his femur just died off because the cells were deprived of blood flow for a period of time. And so that's why he ended up needing a hip replacement and famously came back and played pro baseball after that. He never played football again, but baseball's not as stressful on the body, so he could get by with doing that.
Is that also what happened to Tua? I think that's his name, from Oklahoma.
He dislocated his hip. I don't know.
Have to do with the.
Yeah, I don't know that he tore that ligament. He may have just overstretched it. He didn't have to get his, hip replacement. He might down the road because that extra motion might have damaged some other stuff. But to my knowledge, he didn't really lose that blood flow.
And when getting a hip replacement, do they have to repair that tendon or ligament at all? Or does it just kind of...
They take it out because you're putting in artificial pieces that don't need blood. So you're just putting in a ceramic ball or a titanium ball or something like that.
Gotcha.
So
Okay.
you don't need it anymore. And because it's not supporting anything, it's not critical. But they do have to cut through all these other ligaments and then kind of sew them back up. All right. So let's think about motions. So what motion do you think the pubofemoral ligament would get tight with? So what is it going to restrict?
Abduction?
So it's going to definitely restrict abduction. So if you can't do the splits, horizontal, abduction type splits, your pubofemoral ligament might be too tight, or it could be your adductor muscles might be too tight. So that is the primary thing that's going to block. What about the iliofemoral?
Adduction.
So it will block adduction a little bit, not so much the anterior fibers. If you look at this, the ones that are oriented kind of more vertically, straight up and down, if I bring that shaft of the femur medially, that's going to actually be kind of loose on those, but that posterior part of it is going to get tight because it's really attaching kind of at the top of that greater trochanter. And if I bring the shaft of the femur medially, then the trochanter is going to go laterally. So that would tighten up this side of it for sure.
An extension.
Yeah. So the front one, extension is going to be the primary thing that makes it get tight. If I bring that femur behind my body, that's going to put more tension through that anterior part of that iliofemoral ligament. Does that make sense? And then ischiofemoral, it's going to get tight with abduction to a degree like the pubofemoral, but it's also going to be getting tight when we do internal or medial rotation of that femur. If I twist that whole femur towards the inside, essentially the greater trochanter is going to move more anteriorly, and that's going to make that ischiofemoral ligament get tighter with that. So you don't need to know the motions necessarily that are blocking. I'm just trying to help you think through that. So when we get to some of your later classes, it'll ring a bell and make sense. You do need to know anatomically where they are for sure. All right, let's look at our knee. And then we're getting close to being done, so that's not too bad. All right, so our knee, let's just look at the images. So we've got a bunch of different ligaments. We've got some tendons as well. You can see the big quadricep muscle on the top of this left-hand image. All four of our quadricep muscles, you can only see three of them in this image. One of them is deeper, so we don't see it on the superficial side of things, but they all kind of feed into this patellar tendon. And so above the kneecap, we typically call it the patellar tendon. That same connective tissue essentially extends through the patella, kind of on the top of it, and then it's going to attach to that tibial tuberosity that we learned on the tibia. So that's where it's pulling. A lot of times they used to consider this just all patellar tendon. Now most references say, well, the part from the muscle to the patella is the patellar tendon. The part from the patella to the tibial tuberosity is the patellar ligament. Because a ligament by definition goes from bone to bone, and we're going from the patella to the tibial tuberosity. Other people say, well, functionally, it's still just a tendon. Its job isn't really to support the joint. Its job is to move the joint. So it really functions as an extension of that patellar tendon. But that's the big thing you see in the front. We do have a lot of other ligaments that are running, attaching the patella to kind of help control it. You don't need to worry about any of those right now. We're going to worry just about the ones that are affecting the tibiofemoral joint, not the ones that are impacting the patellofemoral joint. So the tibiofemoral joint is the knee itself. It's a hinge joint, and we've got four primary ligaments. So you can see the fibula, the skinnier bone over here. I had you find this one in class last time. That's our fibular collateral ligament. When we crossed your leg and on the lateral side, you could feel that good band. That's what you were feeling. If you could feel the thickening on the medial side when you're in that cross knee position, then that's the medial collateral or tibial collateral ligament. And then internally, we've got the ACL and the PCL. We'll look at a different image to kind of look at those a little bit better. But those are the four ligaments that you need to know with the knee. Whoops, let me go back a hair. We do have the
Can you real quick state those one more time?
Yes.
So I can just circle them.
This book uses the term fibular collateral ligament. That is also known as the lateral collateral ligament, or LCL. The tibial collateral ligament is also known as the medial collateral ligament, or MCL. And then we have the anterior cruciate ligament and posterior cruciate ligament. So that's the ACL and the PCL. And cruciate refers to crucify because they cross each other. So like a cross. They don't cross this way. They cross kind of more like an X, really. They're kind of like they're on their side, but they do cross inside the knee. So that's where that cruciate name comes from. If we look at this bottom image on this slide, we've got the cutaway. You can see the menisci in it. So menisci is plural, meniscus is singular. And so we have a lateral meniscus that's going to be between the lateral femoral condyle and the lateral part of the tibial plateau. And then we have the medial meniscus between the medial femoral condyle and the medial tibial plateau. And those kind of function like the labrum in a way. They kind of deepen the socket a little bit, provide some guidance to motion, provide a little cushioning like the disc. They are fibrocartilage. They're not only on the perimeter, they are thicker on the perimeter like the labrum, but they do still exist kind of more towards the center portions of them. They're kind of wedge shaped. So kind of wide on the sides, and then they taper down towards the middle. And you can kind of see that wedge shape when we look at this side view. If you look at the back of the knee, you can really see this kind of triangular section. That's just a cutaway view, but it is wider on the perimeter and narrower on the center for both the medial and the lateral collateral, or medial and lateral meniscus. And they're stuck down to the tibia. So they're really attached to the tibia, and the femurs rest on top of them. So when we move the knee, they really are what make contact, not the bone. So the tibia doesn't really directly make contact with the femur unless you've had some of that meniscus torn and removed. The meniscus is normally that primary contact point.
So are there any advancements taking place on repair of that and like degenerative injuries to the menisci, sorry?
It's hard. They don't have great blood flow. They'll usually either do a meniscectomy, which an ectomy is a removal. So they'll remove, they try and leave as much as they can. But if the tear, most cases the tear doesn't heal on its own. If that tear creates a flap that kind of gets stuck in the joint, it's going to cause pain. It can potentially change your mechanics in the joint and cause some joint erosion. So they'll usually just trim it out. If the tear's not too bad, sometimes they'll try and do a repair, where they actually try and stitch the two torn pieces back together again. And it kind of depends on where the tear is, whether that's going to work. But those are really the two primary things that they'll do. A lot of times they'll do things to address the underlying articular cartilage. So when you hear about things like stem cell injections and hyaluronic acid injections, rooster comb injections, things like that, those are mostly designed to try and stimulate the bone, the cartilage on the end of the bone. They'll do other procedures like microfracture procedures, and sometimes what's called an Oates procedure. And those are usually involving the articular cartilage more than the meniscus. The meniscus is just, it has such a bad blood supply that it's just really hard to get it to heal itself. So I think a lot of the things that they've tried just don't work. Even the repairs, person usually has to stay off of it for a long time to try and give it some hope of mending itself and kind of sticking back together again. But it's not a super successful surgery in a lot of cases. But they do try and, if they do have to repair or trim out a meniscus or repair it, they try and leave as much as they can because it's that cushioning, it's that protective layer. It does help kind of guide the motion a little bit and help with alignment. So we want to leave it if we can, but if it's dysfunctional and causing pain, then it can create more problems if we don't do something about it in a lot of cases. All right, let's look at the ACL and the PCL, and you can kind of appreciate these a little bit more. So on these top images, both the actual cadaver specimen as well as the drawn in image, they have the knee bent at about a 90-degree angle. So you're looking at the end of the femur. So that's what this big white area is. That's going to be the exposed kind of femoral condyles. And if we look at my femur, that's essentially kind of what you're seeing. is a view just like this. So you've got the big femoral condyles. Again, if I'm standing up straight, I'm resting right on those parts. But when I bend my knee, now the part that I was standing on is now facing forward, and I'm bearing weight, or I'm making contact with the back side of that condyle. So where my fingers are right here. So that's kind of what we're looking at, is this orientation. And so inside this intercondylar notch or intercondylar fossa right there, that's where your ACL and your PCL are going to be. And when we looked at the tibia, on the top of our tibia, we had that intercondylar eminence, this kind of bony raised area. So you've got kind of depressed areas where the MCL and the medial meniscus and the lateral meniscus would rest, and then that bony prominence in the center. Coming off that intercondylar eminence is where the ACL and the PCL are going to attach, and then they're going to run kind of diagonally and attach onto the femur. And so if we look at the pictures here, you can kind of see that a little bit better probably. Looking from the front, we've got the tibia is the big bone in the front. And so the medial side of the tibia is where that ACL basically originates, and it runs posteriorly and laterally to the backside of the femur. The PCL kind of does the opposite. If we look at the image down below, the bottom of that PCL is closer to the lateral side of the tibia. It's over here by the fibula, and it's running diagonally towards the medial side. So the ACL runs from anteromedial to posterolateral. The PCL goes from posterolateral to anteromedial. And so you can see in this anterior image both of those ligaments kind of crossing. So the ACL goes in front of the PCL, but they're basically just running from opposite points on those two bones. And so their primary thing that they're in charge of is keeping those two bones from, really keeping the tibia from sliding on the femur. So if I've got my two bones here, my ACL, I'm going to show you the side view. So where my finger is moving, that's the front. Your ACL is going to prevent the tibia from moving too far anteriorly. The PCL is going to prevent the tibia from moving too far posteriorly. And so when somebody hyperextends their knee, that's essentially letting the tibia move anteriorly. So that's a mechanism that can tear the ACL, but not really the PCL. Where people usually get their PCL torn is if they're in kind of this position. I come down and I land on my shin, it might drive that tibia backwards, and that would tear my PCL, not necessarily my ACL. Really common PCL injury is a dashboard injury. So a front seat passenger that's in a car wreck, if they're not wearing their seatbelt or the seatbelt doesn't check them in time, their lower leg slams into the dashboard and their femur keeps going forward, but their tibia got stopped because it hit the dashboard. And I actually had a friend that tore his PCL that way. So ACL is also really susceptible to injury when we have too much of this, when our knee dips to the inside too much. That's also a really stressful mechanism for it. And then if we throw a little rotation on too. So most commonly when people tear their ACL, it's either from hyperextension or it's from getting their knee in too much of a valgus kind of position. So if I'm standing here, if I let my knee dip in like this, that's going to be really susceptible injury for my ACL, as is just popping it back too vigorously into hyperextension. And then a lot of times people will come down and land potentially, and kind of maybe they jumped up and they were twisting in the air, and then when they land, they kind of keep twisting. That's also a really common ACL mechanism of injury. So ACL is pretty vulnerable. The the MCL is the second most common injured ligament. The medial collateral ligament will often be able to heal itself because it's part of that joint capsule. It has some other structure kind of surrounding it, but the ACL is kind of in isolation, and it's really hard for those ends to heal themselves. So you almost always have to have surgery to fix an ACL. And if you don't, then your knee's going to be really unstable. If you've truly torn it, then you've lost that ability to kind of keep those bones aligned with each other. So pretty significant injury. You can definitely see them in this guy in these images pretty easily on that medial and lateral side too. Okay. Let's finish the foot and then we'll take our little break here. So the ankle, the proper name for it anatomically is this talocrural. So the crural refers to the crux. Sometimes the lower leg is referred to as the crux. It's also a term that's used in rock climbing. I don't know if anybody kind of does rock climbing. The crux is kind of like the tricky point, the stopping point. That's the hard part to challenge. And the crux is essentially, let me get my foot model here for now. And see if I can pull this guy's foot up here. Bring my friend close. I do need to give him a name, for her name. All right, let me leave my screen share. So the crux.
You know, it's a boy or girl. What's the pelvis like?
You know, there are some features that look more male, and there are some that look a little more female. So I think it's a woman, but I'm not 100% sure.
You could just name it Alex. It could
There you
work
go.
both.
Pat or Chris, you know, could go either way. Any one of those kind of gender neutral names.
How about Charlie?
Charlie, yeah, that's more guy, but there are women Charlie, sure. Sam, oh yeah, something like that. So the crux refers to this U shape where the lateral malleolus and the medial malleolus kind of come down. Sometimes it's kind of like the mortar and tenon, or I think building technique, where you have a pin that kind of goes through to kind of hold. You just put a wood piece in there and wedge it together. But that's what's referred to as the crux, is this kind of U shape. So that's where that name crural comes from. The talus is the talo part. So the top of the talus, that kind of dome-shaped, most superior bone on the foot, is what makes contact with the underside of that tibia. The lateral malleolus or the fibula is really just kind of there to form a bracket to kind of hold things together. And so that talocrural joint is a hinge joint. It's only really supposed to move this way. All the other motions that we can do with our foot are not really taking place at that joint. They're taking place somewhere else in the foot, because we've got all these other gliding joints, these plane joints that can move a little bit. That's what gives the rest of our foot the ability to kind of do some of the inversion and eversion, some of the forefoot ab and adduction type things that it can do, that we talked a little bit about last time with pronation and supination. So the ankle itself, talocrural joint, just a hinge joint, really just does dorsiflexion and plantar flexion. Dorsiflexion is cocking your foot up. Plantar flexion is pushing down into the ground with your foot or pointing your toes. So the ligaments that you need to know, this book is not as detailed as I think you need to know, especially for the lateral ligaments. Let me look at the image, and then I'll hold up my model and we can kind of compare. Let's go back to our screen share. All right, so if we're looking at this foot on the lateral view, so we're looking at the pinky side over here as far as the toes are concerned, you see a bunch of different ligaments holding all those tarsal bones together. You don't need to know any of those. If we look at the distal end of the tibia and the fibula up here, we're going to have a couple ligaments that bracket it that kind of run horizontally. And so these are going to be the anterior tibiofibular ligament running from the tibia to the fibula, and then the posterior tibiofibular ligament. And so those are going to hold that lower leg bones together. So they're running basically right across like this, on the front side and on the back side. And if we jam that foot up into that socket, that's going to put a force on those ligaments that wants to gap them. If you've ever heard the term a high ankle sprain, that's which ligaments get injured with a high ankle sprain. And so now that tibia and that fibula can separate a little bit, and every step is really painful for that person. but it's not really affecting the ankle per se. It's above the ankle actually. The most common ankle injury is going to be a inversion sprain. And so an inversion sprain means we made our foot turn too far into inversion. And so these lateral ligaments get overstretched. If this lateral side of my foot moves further away from that lateral malleolus, that's when those are going to tear. So that's the most common injury at the ankle. And our ankle is not nearly as stable going this direction. Part of that is because the medial malleolus is shorter than the lateral malleolus. If I go into a bunch of eversion, the side of my foot hits that lateral malleolus and the bone kind of stops it from going too far. But because the medial malleolus is shorter, it has more ability to invert and there's not a bone that blocks it. And so then those lateral ligaments are more likely to get overstretched and torn. So your book just kind of uses the term lateral ligament to kind of refer to all of those out there. Because that is a really common thing that we treat, I want you to know kind of the two primary ligaments that actually do get injured with that. And that's going to be the anterior talofibular ligament and the calcaneofibular ligament. So when we look at this image, here's our fibula going straight down from the fibula to the calcaneus. That's our calcaneofibular ligament. And then this one that's going more horizontal, coming off like the front of the lateral malleolus, is going to the talus. And so that's the anterior talofibular ligament. So those two are both considered part of the lateral ligament. They're going to be the most common ones that are going to be torn. We do have another one on the back, this posterior, I think it's a posterior calcaneofibular ligament probably. Actually, you might take it back. It's probably a talus. It's probably a posterior talofibular because we have an anterior talofibular. But the anterior talofibular and the calcaneofibular are the two lateral ligaments that are most commonly injured when we sprain our ankle. And the top one is the most common one, that ATF. So those are the ligaments that you need to know on the lateral side. On the medial side, we have a whole bunch here, and it is pretty strong. We're a lot stronger on that side. And all of these ligaments together are just considered to be the deltoid ligament, and you don't need to know separate names for them. That term deltoid just means triangular, and so that's what we're looking at, a triangular shaped ligament that's holding the tibia to the foot bones to give it stability on that inner side, so we can't move the foot too far laterally. All right, when we look at the other bones in the foot, very similar to the hand, we're going to have plane joints between all those tarsal bones. We're going to have plane joints between the metatarsals and the tarsals. Let me find my foot. So these are all going to be plane joints through here. We're going to have plane joints between individual metatarsals. So these are going to be our tarso-metatarsal joints. So we had in the hand, we had carpo-metacarpal at the base of the hand, at the kind of the base of really kind of the midfoot in the foot. We have those same terms. Instead of carpo, we use the term tarso. So tarso-metatarsal joints. And then we go out further. We have the metatarsophalangeal joints because the metatarsals are meeting up with the phalanges. And then just like the hand, we're going to have a interphalangeal joint, just one of them on the big toe, two of them on all the other toes. In that case, they're going to be the proximal interphalangeal joint and the distal interphalangeal joints. Those interphalangeal joints are always hinge joints. Our big toe doesn't have a saddle joint like the thumb does. It's just going to be a condylar joint there, I believe, that gives us the ability to kind of abduct as well as flex and extend when we look at that. So all of these are going to be condylar joints. through here. The metatarsophalangeal joints are condylar, just like the hand. So we can abduct our toes and adduct our toes, and we can flex and extend our toes. So those are kind of all the joints. It's 9:42, so I went a little over technically for this. So let's take a little break. Let's say until about 9. We'll go 10 minutes. So we'll go till 9:52. And then rather than having you guys work on filling in the blanks on the sheets together to identify these joint structures, we're going to kind of do a different activity, make you kind of think on your feet. And I'll leave it at that. Kind of whet your appetite for what's to come. But take about 10 minutes. I'll see you about 9:52 or so, and we'll pick back up. Well, pretty soon I'll be done with the skeleton, so I can put my skeleton back in the closet, along with all these other bones. Then I can get out the muscle models until we get back on campus, whenever that ends up happening. All right, so we got people starting to come back, so that's good. We are gonna do, let me wait for everybody to make it back, I guess.
Hello, and welcome to the Aperture Science Mental something something. Anyways, to feel mentally reinvigorated, stare at the art. You should now feel mentally reinvigorated.
Okay, I feel like a new man, or at least a new instructor. All right, so we're going to put you guys on the spot a little bit, and this will kind of help everybody get ready for both the written exam as well as for the quiz. Probably not quite as much for the quiz, because that's more about identifying the structures and things like that. What we're doing now is more kind of a mental exercise. I'm going to show you my desktop here. So you can see all these little scraps of paper that I've got. They each have on them the name of either an individual joint, like say the glenohumeral joint, or they have a name like some of the other joint classification terms, whether it's like a pivot joint or a hinge joint, or whether it's a synarthrodial joint or a fibrous joint. So kind of all the things that we talked about in chapter 9. So I'm gonna go just kind of through my roll sheet. I probably have enough scraps for everybody to go for sure at least once, and maybe for most of you to go twice. I don't know if we have time to go through that many, but essentially when it's your turn, I'll let you know. I'm gonna draw a tab. Normally I would have a blue bag, and my students hate the blue bag because they know when the blue bag comes out that they're gonna have to be put on the spot to come up with something. So I'm gonna pick it up, and so let's say, let me find one that's a good one here. All right, so this one is synovial joint. And so if I have a synovial joint, if I drew that, then I'd want you to be able to tell me things about the synovial joint. So anything that you know about the synovial joint. So what are some things that we know about synovial joints in general?
It's a fluid-filled capsule around the joint.
Okay, so we've got that fluid-filled capsule. What else?
Double membrane.
Okay, so we're gonna have that double membrane. We've got that fibrous outer layer, and we've got the epithelial cells on the inner layer that are gonna make that synovial fluid. Okay.
Oh.
Yep.
So it's like a balloon, and it has a fish put into it.
That's more like we had for the pericardium.
Dang it, I had something.
So yeah, it's not quite the same with that. We do have that cavity, but it's a little different representation than like that balloon one. So what are some other features that make synovial joints different from other joints?
Well, it prevents friction from your bones rubbing together.
Okay, so that synovial fluid is going to take away that friction. Why do we need to take away the friction?
Those are freely mobile.
Because those are our most freely movable joints. So all of those would be kind of things that I'd want you to be able to come up with if you drew synovial joint. But we'll take that out of commission since we already gave everybody the answer. If you get an individual joint, like say the glenohumeral joint, then I want you to identify what type of joint it is, what specific type of synovial joint it is, which motions can occur in that joint, would be the other one. And then kind of thinking about the axis potentially of those different motions too. That might be a stretch, but for sure at least what motions that joint can kind of do. So those would be the things that I'd kind of want you to come up with depending on what joint you draw. If you draw something that's a little more specific, instead of like synovial joint, let's say you drew hinge joint, then I'd want you to let me know that it's a synovial joint, and then give me like at least one example of a hinge joint in the body. Does that make sense? And if you're not coming up with stuff, then I'll kind of try and prompt you a little bit to see what else you can come up with. And if you kind of get stumped, then we'll let you kind of sit and stew for a while, and then we'll let everybody else kind of help a little bit. So there's no grade.
This is going to be embarrassing.
It's just about, well, you never know if you're going to get a hard one or an easy one. That's kind of how it shakes out. So,
I
right,
didn't
so-
even do this for the skull bones. I know those well, but not the joints. You
yeah, but we already took that quiz, so we're getting ready for the next stuff. All right, so I drew the first one, and I'm just going alphabetical by last name because that's what I've got sitting in front of me for the roll sheet. So Madison, you're up. We have the 2nd through 5th carpometacarpal joints. So tell me about the 2nd through 5th carpometacarpal joints. If you can point them out on your own body, that'd be great. You don't need to disrobe, so don't worry about that. You can point through the skin. For that one, you shouldn't have to disrobe anyways. It's not like you shouldn't have any gloves on. But tell us about the 2nd through 5th carpometacarpal joints.
Okay, I'm trying to find it in my notes. 1 second.
Notes. It's not up here.
Oh, I can't use my notes.
See what you can do up here.
I feel like this is a hard one.
Well, yeah, it kind of is. We did just talk about it briefly, but we talked about a lot of different stuff briefly. So yeah, but that's okay. It's all about learning for everybody else too.
I don't know.
Curse of being at the top of the alphabet. So what general class of joint would that be? When we look at kind of our structural and or functional classifications of joints.
It would be
Do we want them to move?
synovial.
So it would be synovial. Okay.
Hmm.
So that's our structural classification. Functionally, it's a diarthrodial joint because it's freely movable. Okay. And so then which type of synovial joints are those?
Mm,
So we're talking about the joints kind of right here, kind of running across where the,
a plane joint.
yep. So they're all going to be plane joints. So there's no true axis of motion, no true plane that they move in. They just kind of move a little bit in every different direction. So that's kind of all you would need for that particular one. So kind of
Okay.
classification, general type, which specific type of synovial joint, and then what kind of motions we might go through. All right, so Abby Bailey,
Okay.
you got a little bit of an easier one. So we got suture. So what type of joint is it? Where would we find them? Things like that. How much movement would we want?
Sure. Okay. So that's between the skull bones.
Okay.
Is that right?
Yep.
Okay. And then what do you say after that? Movement?
Let's say what functional and what structural joint types would that be?
To kind of, I don't know.
Okay. So do we want those things to move much?
No, but they do like, don't they like get, when you like get older, they like get stronger, right?
Yep. So they're gonna move less and less as we age,
Right.
kind of firm up. So if we have from a functional standpoint, what do we call those type of joints that don't move much or aren't really supposed to move?
Shoot, I don't know why I can't think of the name right now.
So the last joint we had was a plane joint, and it was synovial. It was diarthrodial. So the synovial for that one is the structural type. The functional part was the diarthrodial because it's freely movable. So from a structural standpoint,
synarthrosis or something like
it
that.
would be, so yeah, that would be our functional category. It would be our synarthrosis. Kind of, it's a synarthrodial joint. It's not meant to move. And then
Alright.
structurally, kind of how is it held together?
Fibrosis.
Yep. So we're gonna have a
Got it,
lot of
yeah.
fibers. So just fibrous.
Oh, okay.
Yeah. Fibrosis is actually another term that kind of means like a scar tissue buildup. But fibrous would be the kind of the structural type. Functional type would be synarthrosis with that one.
Mm-hmm.
Okay. All right, Tara. We have the interphalangeal joints. So see if you can point them out on your body, and then what type of joint it is and what kind of motions we would have in that.
All right. Hmm. Sorry, I've studied the ones from the last one, but since we just went over them, it's hard to
Right.
remember them off the top of my head.
Yep. So where are they? If they're interphalangeal.
They're either your fingertips or your toes.
Okay. Yep. And so what kind of motions can they do?
They bend your fingertips.
Okay. And so what plane do they make our fingers move through?
Trying to think. I'm sitting here doing this, trying to get it right.
And I would encourage you to do that during these tests. It
Yeah.
helps you to move around. It'll help you figure out what's going on. So if you're in anatomical position and you do that motion, which way are your fingers going to move? Which plane?
Well, aren't they moving forward and backwards?
Uh-huh.
So it'd be anterior and posterior.
Yep. And so that anterior to posterior plane is our sagittal plane. Do they move in any other planes?
Can't they go abduction and
So the abduction and adduction part of the hand is going to
right
take,
down here? So it would be
Oh,
so we're talking about more distal than that.
I'm trying to think. Can they do extension and flexion?
Flexion extension would be our motions. Yep. So that's just one plane of motion. So they're going to be a uniaxial joint type. They are synovial joints because they are moving. And so which type of synovial joint, if they only move in one plane, and that one plane is the sagittal plane?
They're uniaxial.
Yep. But we've got
Would they be the plane joints?
they're not going to be plane because our plane are going to be where we have kind of flat surfaces that
Okay.
kind of glide a little bit.
So it'd be, is it the pivot ones or the hinge ones?
So what do you think? So
Trying to remember.
okay. So do you, when you do that motion, do you think of that as being a more of a hinging motion or more of a pivoting motion?
I think it's more hinged motion.
More of a hinge. Yeah. So those are hinge joints. They just move in that one plane. They're uniaxial. They're synovial. So all of that. Okay. All right. You're off the hook for now. All right, Audrey.
Yes.
Let's see. All right. So you got synarthrosis.
Okay.
So pick something new. We already talked about the sutures. So we need to come up with a different synarthrodial joint.
Okay, so they're immobile joints, right? Synarthrosis joints are immobile.
Yep.
So would like the carpal ones be synarthrosis because they don't move a lot, or are those plain joints?
Those are going to be plain.
Okay. I don't know. I'm not sure. I just think of the sutures.
Okay. So you've got some that are going to be fibrous that are synarthrodial. We've got some
Like
that are going to be
the vertebral
cartilaginous.
joints?
What's that?
Like in the vertebrae, like the vertebral joints?
The vertebral joints, we do have a little bit of motion. So
Uh-huh.
those are going to be different than synarthrodial. Those are going to be amphiarthrodials if we look at the bodies of the vertebrae.
Mm-hmm.
So we want something that doesn't move.
Is there a joint between like your coccyx and like the hip bone?
So essentially where like the sacrum is fused together, that would be like a fibrous joint where the different vertebral levels that make up the sacrum, then that would be a
They
fibrous
fuse?
type of joint that we
Uh-huh.
don't want to move. Not necessarily between the hip socket, but between
Yeah, but just like,
sacrum and then the individual sections in the coccyx. Those would all be considered fibrous joints that we don't really want to move.
Okay.
What would be another fibrous joint? That is synarthrosis. Okay, Whitney's going like this. Okay, so
Or
all those teeth.
teeth? Okay.
Yep. And we'll go ahead and use that. Since we don't have a ton of time, I'll probably go ahead and let somebody mention what that one's called. And then if I draw that one later, we'll just throw it out. What do we call that articulation between the teeth and the jaw?
Gomphosis?
Okay, so that's our gomphosis. Okay.
Perfect.
So the sutures and the gomphosis, that's really the primary fibrous joint types
Mhm.
that we're going to see. I'll hold off on the cartilaginous one in case we get that one for somebody later.
All right.
All right. So Tom, you're the man. All right. So we got the first carpometacarpal joint.
So the carpal metacarpal joint is going to be between the wrist bones and the metacarpals.
Yep.
It's going to be a plain joint.
So 2 through 5 that Madison had, I think, is going to be the plain ones. If we're talking about the first, which digit are we talking about?
The thumb.
Okay, so we're on the thumb.
So that's opposing, but I can't think of the name for that.
Okay.
Can we hold on for a second? There's someone having a piano play in the background
I hear that.
with the microphone on. Is that you, Allison? The mic's on.
I've got a special needs daughter that we have a little trouble
Okay.
helping understand when we have that problem. So I'm trying to get it taken care of right now.
Oh, that's fine.
Never mind. It's all good.
I thought it was just heightening the mood, having this little,
Little background
like
ambiance.
Jeopardy, Final Jeopardy. They have a little song that plays in the background. Yeah.
All right, sorry to distract us. So what were we talking? The thumb and
The
what kind of
first-
joint that was?
The first CMC joint. So right down here. Yep, right in there. So it's special.
And I can't think of the name of that.
Okay. We did this little activity.
So that's a saddle joint.
Yep. So that's gonna be our saddle joint, and so that's why it can oppose. So you mentioned that opposition. So it's gonna move in kind of like 2.5 planes. It's gonna be able to move into flexion extension. It's gonna be able to do abduction, and then it has that kind of diagonal kind of opposition function.
Was that one that you identified as that you wouldn't necessarily always call saddle joint, or are we just strictly talking about the pectoral girdle with that one?
No, that one's pretty much any reference you'll ever look at considers the thumb to be the saddle joint. The sternocleidomastoid joint, sternoclavicular joint, is the one that's some books say is plain and some say it's saddle. So a good question. All right. So Allison, we have the metacarpophalangeal joint. Okay, so
Okay, so metacarpal phalangeal, between the metacarpal and the phalange, and it is Oh goodness. It's a synovial
Yep.
because it's movable. And it is I know. It in the anatomical plane, it moves in the sagittal plane. They move in the frontal plane. And because they can do those two motions, they can do the circumduction.
Yep.
And what else do we need?
The joint type.
Oh, joint
We know
type.
it's synovial, but which of the 6 synovial ones is it? It moves in those 2 planes.
You I know we don't have a lot of time. It's multi-axial, right?
Well, it's only moving in 2 planes.
You
Biaxial.
biaxial, and then something else.
So we've got 6 specific synovial types.
Not condylar, is it condylar?
So
Okay.
condylar. Yeah.
Okay.
So condylar on that one. All right. Nick. I already had synovial. I don't want that one again.
You can give it to me again. That's fine.
No, we got plenty others to choose from. All right, so we got radio ulnar.
Okay. So it's a synovial joint.
Yep.
It's pivot.
It is pivot.
Is there what else do you need to know?
So what motions can it do?
Let's see. It's with the radius and ulna.
Kind of how many planes does it work in? And which plane does it work in?
Well, I guess that'd be the sagittal plane.
It's not going to be sagittal. Our hinge joints are going to be our uniaxial ones
Okay.
that are sagittal. I probably shouldn't have told you uniaxial.
Yeah, I'm not really sure.
Okay. So how many do we have? So radio ulnar, we got our 2 forearm bones.
Mm-hmm.
So what
I'm sorry. How
part?
many? So there'd be 2 of them, right?
There's 2 of them, yep. So we've got one that's close to the elbow,
Mm-hmm.
and we've got one that's close to the wrist.
Proximal and distal.
Yep. So proximal radio ulnar here, distal
Mhm.
radio ulnar up there.
Okay.
They are pivot. So when we think about pivoting, what plane is that happening in?
Let's see, pivot.
Think about if you're a basketball player and you've got your pivot foot down,
Uh-huh.
what plane is that motion occurring in if I'm pivoting back and forth?
Coronal. I'm just trying to step back. I'm not really sure, to be honest with you.
Okay,
Guess and check type work.
you got the pivot part right. So that was good.
I'm working on it.
Yep. So
Plane's the hardest.
No
the
kidding.
plane's the hardest.
Mhm, the plane, yeah.
So where else do we have pivot joints? Where's the other big one that we talked about?
It's the axis and the atlas.
Okay, yep. So the atlas and the axis, and that's what gives us that ability to do this with our head. So if we're turning our head side to side, we've got a vertical axis, and we're rotating that head to the right, rotating that head to the left. When we look at the forearm, when we look at those radial ulnar joints, we are pivoting, but essentially we're going like this, we're going like this. So it is still a vertical axis coming straight down in anatomical position. And we call this palm down position something. We call that palm up position. something.
Supination.
Yeah, pronation and supination.
So we got pronation is that palm down.
Uh-huh.
Supination is that palm up. Okay? So that's kind of our for those radial ulnar joints, that's what they're going to help with.
So
And that's what they're going to let us
is
do.
your hip a pivot? Because you can turn your like upper torso side to side and your hip stays in place.
Those are because of the hip joints are multi-axial, so that the hip movement is what lets us rotate, and then we do have some rotation through the spine, but they're not classified as a pivot joint. It's because each vertebral level can kind of add up together and they can each turn a little bit, but it's because those vertebral joints are plane joints that are giving us that ability to kind of add up that rotation, with the exception of C1 and C2. So that's the only pivot joint in the spine. Okay. All right. Got to make sure we get through everybody at least once. I don't want to leave anybody out.
Were you looking for transverse plane? Was that the plane
Yes.
that we were looking
Yes,
for?
that would be a transverse plane. Yep. Good point. All right. So Amanda, we have syndesmosis. So what type of, so that's our, that's basically one of the types of one of the classifications within fibrous joints. I'll give you that. So where do we have those? What movements do they allow? Do we want a lot of movements with this joint type? Do we not want a lot of movement with just this joint type?
Let's see. It's kind of like the stuff that's in between the radius and then the ulna, right?
Yep.
So
Yep. So what do
is
we
it just
call that?
connections between the two?
So we're going to have that connection between those two forearm bones as well as between those two lower leg bones. What do we call that whole section of tissue that make up a syndesmosis?
Like the interosseous membrane? Is that-
Yep. So the interosseous membrane. Okay. Interosseous. Osseous just means bone. Inter between. So it's a membrane between those two bones. Just essentially a sheet of connective tissue. So do we want motion there? Do we not want motion there?
No motion, because that kind of stabilizes the ulna and the radius together. So no motion. So
Okay. So we've got those two different ones. We've got the one in the leg. We've got the one in the arm.
yeah.
If I'm doing, we just talked about the radial ulnar joints. So if I'm doing pronation and supination, I'm
So you do want some motion so that it can move.
relative to that ulna, and that sheet of interosseous membrane is kind of in there, so it is moving some. With the leg, it doesn't. With the leg, we do need more stability since we're bearing weight on it. We don't really want those things to twist a whole lot like the forearm. So we do allow a little bit of movement with that joint type. So what's that term that means the joint moves a little bit?
Amphiarthrosis.
Yep. So amphiarthrosis. It's kind of like you think about amphibian. They can kind of live in two environments. Amphiarthroidal is stable, but with a little bit of mobility. So it kind of lives in between stable and mobile. And the syndesmosis in the forearm is a lot more mobile. The syndesmosis in the lower leg is a lot more about being stable. But they do both allow for a little bit of motion. So amphiarthroidal.
When we twist our ankle, we don't get any movement between the tibia and fibia?
Well, if you get that high ankle sprain, you're going to get a tiny bit, but it's not going to be like the forearm when we can really turn the whole thing over. We can't like turn our foot around backwards to let that much twisting happen in the lower leg. If you get that high ankle sprain where those two bones gap because say the foot gets jammed up into that crux too much, then that'll make them separate this way. And that's partially what that syndesmosis is designed to prevent. Plus those horizontally oriented tibiofibular ligaments would also hold things together to keep that from separating and twisting apart. All right, 10:23. I still got a ways to go. Got about 8 people left, maybe 9 people left. All right, so Whitney. We have synchondrosis.
All right. So synchondrosis is a part of the, what's it called? Cartilaginous one, because there's made up of cartilage.
Yep.
You see one examples.
Yep.
In between, or not in between, the ephegeal plates, correct? And those are immobile, so synarthrosis.
Okay. So they are supposed to be synarthrodial. We don't really want them to move. That the example that you gave is one that this book talks about. Most other references don't, because really we don't, even though it is a cartilage piece connecting two bony segments, it's not really supposed to move. So what's the other synchondrosis joint that, again, it's not going to move with the joint, but we want that body part to have some mobility to it. We've got kind of one other primary example of synchondrosis joints besides that epiphyseal plate, which again, some references don't really think of that as a joint.
You said you want some mobility in it?
That
No, it's synarthrosis?
not necessarily at the joint itself, but in the region
body
where
itself.
those other synchondrosis joints are, we do need to have a little bit of motion.
Is it up here? I'm pretty sure it starts with a C.
Yep.
Costochondral?
Okay, yep. So costochondral. Costochondral. So the costo part refers to the ribs. Costo means rib. So where the ribs and where that cartilage chunk is connecting the ribs to the sternum. That's our other synchondrosis joints. And we don't really want the bone and the cartilage to move at either end, but the fact that that little strip of cartilage is flexible is what lets us be able to kind of have some motion there when we breathe in and breathe out. And even when we twist, you know, or if you're doing CPR on somebody, it's going to give a little bit because of that flexibility of the cartilage. But the motion isn't really happening where the cartilage joins the bone.
Okay.
Okay. Right.
Isn't the pubic symphysis is also the same?
That'd be different. Actually, we haven't gotten to that joint type. So that's still that's another cartilaginous type, but it's a different cartilaginous type. So maybe somebody will draw that, or maybe I'll draw that for somebody. All right. Next up, Olivia. Olivia has the talocrural.
It's near your ankle, right?
It is your ankle.
Your ankle.
So that's pretty near. Yep.
I'm trying to think of what it would be.
So what big class is it? When we look at functional or structural?
It's because it's like it's not completely mobile. Well,
so what can you do with your foot? What does your ankle do?
Well, you can do like it's called like plantar flexion and dorsiflexion, right? You can like put it up and down like this.
That's kind of a tricky one. That's considered to be in the sagittal plane. It's a little different since the foot's like this on our leg instead of being in line with our leg. But it is considered a sagittal plane motion, that dorsiflexion, plantar flexion.
So would that be a hinge motion?
Yep, it is a hinge.
I'm trying to think of what it would be.
So when we look at a functional classification, if it moves a lot and it's a hinge joint, then it's going to fall under the synovial
Oh, yeah.
functional class. And then how about the structural class? And then the functional class are all those ones that kind of end in arthrosis or arthrodial. So which type of functional class is it?
Would it be diarthrosis?
Yep. So it's going to be diarthrodial, hinge joint, moves just in the sagittal plane. Again, we do have a lot of other motions at the foot, but the only one that really takes place at the ankle is that dorsiflexion and plantar flexion. And talar curl is the ankle itself. All right, Bryson. Find a good one here. All right. So we got amphiarthrodial. We already talked about the syndesmosis, so you can't use that one. That one's off limits. So what's another type of amphiarthrodial joint? And tell me kind of structurally which one it is. So we talked about amphiarthrodial already, meaning it's not 100% stable, it's not 100% mobile.
Yeah.
It moves a little bit.
Trying to think this because wasn't that the membrane in between the bones that we talked about last night? Was that the same thing?
Yeah, well, so that's a syndesmosis.
Okay.
So a syndesmosis is a type of amphiarthrodial joint that is fibrous. We have another type of amphiarthrodial joint that is cartilaginous.
Does that have to do with the discs, intervertebral discs?
Yep. So our discs and our pubic symphysis are going to both be symphysis joints. And so symphysis joint is a type of cartilaginous joint that allows a little bit of movement. So that's our amphiarthrodial. So the intervertebral discs, as well as the pubic symphysis, those will be your primary examples, besides the syndesmosis, which is the fibrous type of amphiarthrodial joint. Okay?
Yeah.
See how all those kind of fit together. All right. Eric, you ready, man? No pressure. Okay.
No.
All right. Glenohumeral. Where's it at? What's it do? What type of joint is it?
Okay. Could you tell me where it is? And
Well, that's what I'm asking you. Glenohumeral.
Well, I wasn't really prepared for this other than other
I
bones.
don't think anybody was. That's the point.
Well, that's just evil.
Pretty much. Trying to give you a wake-up call, but in a good-natured way, you know.
Okay.
How I roll.
Do you have a study guide for this that I could learn about it later or something?
I will put together a study guide for the joints as far as the ligaments. I'll do that after class, so you know which specific ones you need to know for a given joint. But let's just talk about what's in that name, glenohumeral. What's it telling you?
Humeral.
Okay.
Maybe it's in the humerus.
Okay. And so our humerus is which bone?
Well, it's this bone right here.
Okay. And so what's gleno refer to? It's not a nickname for Glenn. Like, Gleno, yo, what's up?
Not glycose because that's sugar and
Yep.
there's nothing to do with sugar in your arm.
No.
Your shoulder. Yeah.
What's our humerus attached to? This
Oh,
guy.
your scapula.
Yep.
It's connected.
Not scapulohumeral. It's glenohumeral. So what part of the scapula? We need to look at this. And so right there is our glenoid.
Oh, the glenoid cavity. Okay.
Cavity. So that's glenohumeral. So what motion, what kind of joint is it?
Ball and socket.
Ball and socket. So how many planes of action does it move in?
All of them.
All of them. Is that what you said?
Yes.
Or is that what I said?
No, that's what I said.
Okay. So what are those 3 planes? Can you demonstrate those motions?
Up and down.
What do we call that?
Superior and inferior.
No.
Uh,
It's moving in that direction. If I'm like this, that's a certain motion. If
Like
I
a
go up and down like this, that's a different motion.
okay. So this is it's not transverse plane.
No. It does move in the transverse plane, but that not with this motion or this motion.
Not the coronal plane because it would be the front and back.
Okay, so when we do this in the coronal plane,
I'm trying to figure out. Wait, don't tell me. Like that one radio show.
yeah,
Okay. So
if we move something away from the body versus moving something towards the body.
okay. So okay, I'm figuring this out. It's something to do in half. It splits the body. Okay. What's the first letter?
First letter of this, either
Yes.
direction, it's A. If I go this way,
Asymmetric.
it starts with A. If I go this way, it starts with A.
Give me a second letter.
All right, we only got, what, 5
Okay.
minutes? 6 minutes.
Well, I can tell you there's the coronal and the transverse.
So this is coronal.
Oh, wait,
This-
what? I thought I said that.
That's the plane, but what is the action that takes place in that plane?
Oh,
If I raise my arms out to the side, I bring my arm away from my body, I'm abducting it. If I
oh,
bring it back down towards my body, I'm adducting it. I'm adding it back to my body or I'm taking it away from my body.
yeah. Those were not in my
If I go this way, straight in front, I'm in the sagittal plane and I'm flexing my glenohumeral joint or I'm extending my glenohumeral joint. Okay. And then transverse plane, I can rotate. And usually we'll have people bend their elbows so we can kind of tell really what's going on with the humerus. So if I do this motion, I'm internally or medially rotating. If I go that direction, I'm externally or laterally rotating. Shoulder will also move in the transverse plane like this. And so that's our horizontal adduction and horizontal abduction. Okay?
Well, I know what I'm gonna be studying: the abduction and the other one.
There you go. All right. So we got 5 people, six people left still. All right, we got like a minute apiece on this. So Lisa, you better be on it. All right. I think we already talked about everything that falls in that category. It was fibrous. We already talked about amphiarthrosis. I gotta find a good one that we haven't talked about yet. All right, here we go. Humeral ulnar.
Oh.
So the humerus and the ulnar right here at the elbow
Okay.
would be a hinge.
Yeah.
You could go the flex and extension.
Okay.
And would you go the ab and adduction too?
If it's a hinge, it's uniaxial. So it's just going to do that flexion extension.
Okay.
And it's a synovial type. So it's
Synovial.
radial. So she nailed it. I think that was like 35 seconds or something. I'm ahead of schedule now. Thanks. Appreciate it. All right. We got our other Abby, Melver. So we got tibiofemoral. Wait, is she here? She's not here. Never mind. Let's go. That makes me move one ahead. So Shannon, we're on you. So tibiofemoral. Can't hear you. You have a mic? It shows you unmuted, but I don't hear you.
Did that work?
Yes.
Okay. What was it again?
Tibiofemoral.
Okay, so that's the knee.
Yep.
Your tibia and femur connecting. Synovial, because it moves.
Yep.
Hinge, because it's uniaxial. In the sagittal plane.
There you go. So that's pretty much it for the knee. Yep. Spot on. All right.
Talk about the roses thing.
What's that?
Aren't we gonna talk about the roses thing where it moves like diathesis?
Tell me one more time. What type of for the knee?
Yeah, isn't it like?
It would be, since it's synovial, it's going to be diarthrodial.
Yeah.
Diarthrodial is the synovial. All the synovial ones are diarthrodial.
Right. So there's no roses. Yeah, I mean the stuff that ends with roses, throsis.
Diarthrosis is the same thing as diarthrodial. So
Oh.
it's just kind of changing the ending, but it basically is meaning the same thing. So diarthrosis. Yeah, if we look at synarthrosis, amphiarthrosis, and diarthrosis and diarthrodial is essentially the same. All right. So Kim, we have condylar. We already talked about the MCP joints. So what's another condylar joint that you can think of? Got a couple other options that I can think of off the top of my head.
So is it the same for the tarsals and metatarsals?
Yep, so MCPs and MTPs would both be condylar joints that have those two planes of motion, biaxial. So what other ones do we have? So rather than thinking of something off the top of your head, you might think of something off the bottom of your head.
So is that where your skull, your occipital condyles hit the atlas?
Yep. So where the base of the skull sits on top of C1, that's going to be a condylar joint. We
Nice
can do
pun, by the way.
extension, and we can kind of let our head tilt a little bit side to side on there. So that's going to be more that like abduction and adduction essentially of the head.
Okay.
So that's an example. And then the radiocarpal is kind of the other big one in the wrist that's considered condylar.
Okay.
Okay. All right, Ashley, we got two left. I know I'm overtime, sorry. We're going with plane. And it has to be something that we haven't talked about yet.
Oh, geez. Looking for a second.
I don't know that we've really talked about a lot of them plane ones, but
We talked about all the ones in the hands, right?
okay. Yep.
And don't we have one in the foot?
Yep. So all those articulations between the tarsals in the foot, between the carpals in the hand, those are all going to be plane joints that just glide a little bit, kind of in every different direction. What's another one besides in our extremity? Do we have some planes in our axial skeleton?
Oh yeah, aren't they all the vertebral discs?
So the discs are going to be our symphysis here, but on the back side, where all those facet joints are, those are going to be plane joints. They're going to be synovial. They're going to have some motion. They're going to be considered diarthrodial, all that. All right, Mo. Last but not least. Got to find one we haven't done yet. All right, here we go. Acetabulofemoral.
Okay, that's gonna be the femur
Yep.
and the tibula.
Um,
The acetal. I think that's the top of the femur.
Yep.
So this is a synovial,
Yep.
and it's I think it's plain. No, it's a uniaxial. I think.
So what's the acetabulum?
Oh, it's. I think it's the socket itself.
Yep. So the acetabulum's the socket on the pelvis.
Oh, so it's a hinge, and it's because it moves it just in one. Oh. So it moves in multi.
Okay. So
And
multiaxial.
so it moves in the frontal, and it moves in the sagittal, and it moves in the transverse.
Yep. So we can
So
rotate the hip.
Adduction, it does flexion, extension, and it does rotation.
Yep. Internal and external, or medial and lateral rotation. All right. So hopefully you enjoyed that. I'm sure we'll do more activities like that as we go, where I kind of quiz you on the spot.
That was stressful.
I'll get to work on trying to give you like a handy kind of shorthand of which ligaments you need to know for which specific joints. But for sure you'll need to know joint types like we just kind of talked about with all these different joints for both the test coming up as well as for the quiz. The quiz is going to be more likely to have images asking you to identify, particular joint names, particular ligaments, things like that. The exam is going to might have some of those images too. So there will be some overlap between these two things coming up next week with that. But I'm going to let you guys head out and let me know if you have questions, but I will get that kind of brief breakdown of which ligaments you need to know, which joints put together, and get that posted for you. There's your study guide up. But otherwise, just shoot me a message if you have a question, and I'll get to it as quick as I can. And don't look for me on Saturday, though. I'm doing a 50-mile race on Saturday, so I'll probably be out of the office for a while. You can hear about it on Monday if I can move, or Tuesday if I can move.
Good luck. Be safe.
Thanks. Appreciate it.
I'd like to make an announcement for my group. We're going to meet up today at 5.
Okay.
Yeah.
Sounds good.
Everyone else. Bye.
See you, Eric.